again we'll check for the flow of CSF. Then we connect the three-way.
and adequacy of dissection. So it is not useful for preservation of eloquent cortex unless it is used for the simulation or record auditory or visual cortical recordings. So this is small video. So this is a patient position. We use the image guidance for accurate planning of craniotomy. You can notice the large craniotomy in this case. We do a virotomy. This is how we place our grades, and we take intraoperative photographs to see the position of various inputs and we record. This the small table shows how we do echo grading. This patient had echo grade for parietal surgery. This is the motor mapping as it was located in the posterior cortex. Based on echo, we dissect our tuber. So we are doing following the section. We recorded it again, and there was insufficient echo improvement. Then we did the second reading, and this was the final echo reading. Yes. So the another case. So when to do echo guided decoction resection, when the particularly it involves non-eloquent localization, FCD, and post-plastic and tuberous sclerosis, we should not do in eloquent cortex, small tumors, and MTS. The complications, it needs larger craniotomy, need for the reopening, more blood transfusions, higher rate of infections. To circumvent these complications or disadvantages, we are moving to the stereoencephalography, which is very thin catheter. The electrodes are placed inside the brain for the same purpose. So we are almost abandon the echo for the diagnostic purpose. We're doing FCG for diagnostic purpose in our institute. We have operated so far more than 1,000 cases based on echo and with a good surgical outcome. Echo can be a good valuable tool for the resection and map the eloquent cortex. FCG almost replaced echo for the diagnostic purpose. Thank you. Good morning, everybody. I'll be presenting a case on left CP angle epidermoid operated by Professor Deepak Gupta and Dr. Kopla Prani. This was a 17-year-old male, Abhishek, who presented with decreased hearing, and he had presentations of hemifacial spasm. And this is MRI showing diffusion restriction, but mostly suggestive of an epidermoid. And regarding the position, he was kept on a right lateral position, where the points to be noted in this position are the bony prominence are to be padded well, and the shoulder, which is not supported down, should be hanging freely, and it should be retracted caudally and fixed so that there is more workspace for the CP angle to get explored. And as you can see, we are using an image guided system to perfectly localize the sinuses and localize the sinuses so that we can minimize the sinus injury intraoperatively. And the craniotomy is placed based on the IGS. And we used a lazy S incision. And as you can see, there is a mastoid which is being marked as a summit. And it is to be noted that this is the highest point which is to be placed on positioning the patient. And a bit of neuroanatomy based on rotum. These are the neurovascular structures arranged in CP angle. The point to be noted is the fifth nerve is most interior,
And ninth, the lower cranial nerves are placed superficially. The first CSF is drained off, and as we open the CP angle, there is a pearly white SOL, which mostly goes out with epidermoid. There is only without any sharp dissection, only with the use of suction and penetrated cup forceps. We are trying to remove all the tumor without any damage to the neurovascular structures. And the dissection proceeds in a blunt fashion without any use of sharp instruments and without the use of any retractors. We are using an intraoperative monitoring to localize and preserve seventh nerve. It is to be noted all the veins which are important in cranial surgery to be preserved. And we are also using an endoscope to localize the leftover tumors which are not seen with the microscope, and thus to remove the same. There was a small bit of tumor present at the proximal aspect near the internal aquatic meatus, which was removed using an endoscope. Now, there was, as we can see, there is complete removal of the tumor, which was inspected using an endoscope and was rechecked after microscopic resection. The arteries and the nerves are well preserved. The lower end of the lower cranial nerves are being visualized. The lower cranial nerves are being monitored. And the dura is closed in a watertight fashion, and the craniotomy is placed back with mini plates, and the wound was closed in layers. And this was the patient before surgery, having facial tics, and this was just before discharge, without any features of hemifacial spasm, and is completely relieved of symptoms. And the post-operative MRI showing almost a complete resection. Thank you.
Good morning, everyone. I'm Dr. Nidisha, and I'll be talking about the telovelar approach. This patient was operated by Professor Suri and Dr. Rajiv Sharma. Telovelar approach is used for tumors infiltrating into the fourth ventricle or when we want to enter the safety zones in the floor of the fourth ventricle. This patient is operated in the prone position with the head neutral and as much flexion as possible, taking care not to compromise the patient's respiration. The incision is tailored to the craniotomy. We usually take the incision from the inion to the C3 process. The suboccipital region is then exposed. Burrholes are placed paramedian to just below the inion. A midline suboccipital craniotomy is made and the foramen magnum rim is removed. Depending on the exposure needed and the infero-superior trajectory, the posterior arch of C1 can also be removed. The dura is opened in a Y-shaped manner. The arachnoid is also opened to relieve the pressure in the posterior fossa. The right durotomy and the left durotomy is then made. The falx cerebelli is also cut open to retract the dura superiorly. It's based on the transverse sinus. The dura is then tapped superiorly. The arachnoid over the cisterna magna is open, and at this stage we should be able to see both the tonsils clearly. The right tonsil and the left tonsil are mobilized laterally using sharp dissection, dissecting away the arachnoid bands. This lateral dissection helps us reach the lateral recess and also increases the superior exposure. Both the tonsils are then mobilized and retracted superolaterally so as to expose the roof of the inferior part of the roof of the fourth ventricle clearly. And at this stage, after retracting the tonsils, as seen over here, we can see the foramen of Magendie clearly. On adequate exposure of the inferior part of the roof of the fourth ventricle, we should be able to see the tela inferiorly and the inferior medullary velum superiorly, which connects the nodule and the flocculus. The inferior medullary velum is then divided after dividing the tela. Here the tela on the right side is divided so as to increase the exposure laterally. The tela between the vertical limbs of the choroid plexus is also divided, and at this stage, in this still, we can see the striae medullaris clearly. The uvular tonsillar fissure can also be opened to increase the operating space. The dissection is carried out to increase the operating space as required. By the end of it, we should be able to see the floor of the fourth ventricle clearly. All of these structures should be seen, and even the safe entry zones on the floor can be seen. Since this approach provides equivalent exposure as that of the transforamen, it clearly trumps over it, and transforamen is thus almost a redundant procedure. Thank you.
Good morning, everyone. Myself, Dr. Siddharth Joshi. I am presenting case of the cervical laminoplasty operated under Dr. Sachin Borkar, sir. Case is the 50-year male patient presented with a history of the fall from the first floor. The MRI showing the C5, C6, C6, C7, C4, C5, C5, C6, C6, C7 PIVD post-traumatic and with the cord compression. This is how the orientation, this is cranial end, this is caudal end, this is the left side and this is right side. Patient prone patient position in prone position. And now we did the subperiosteal dissection to expose the lamina and facet joint. After the subperiosteal dissection, we marked the lamina between lamina and facet joint. We did open door the laminoplasty, in which we made open door in the right side and made hinge on the left side. With the use of bone kissa, we opened the door on the right side at the lamina facet junction. And with the help of the diamond drill, we thinned out the lamina facet junction of the left side and made hinge at the left side. Now we are in the opening the door on the right side and dissecting the beneath the ligament of flavum. The care should be taken at this step to for the dorsal venous plexus vertebral artery. It can be injured at this place. This is how we dissected the ligament of flavum. This is the cranial end of ligament of flavum. Now we we bend the mini plates in the shape of the Z, and we open the right side of the door and fix this plate on the right side. This is the post-operative scan of this patient. This showing the adequate canal decompression. Thank you.
Good morning, everyone. I'll be presenting an approach to craniopharyngioma. The patient was operated by Dr. Rajiv Sharma sir on 11th of February. A brief intro, this is all theory, I'll move forward. The goal of this presentation is basically to understand various approaches that we'll be seeing here, and the approaches that were planned and the approaches that were eventually executed. Basically, in this diagram, I'd like to show this is the corpus callosum, this is the anticommission, rostrum, anticommission, the lamina terminalis, the optic chiasma, and posterior and the pituitary. We should know the anatomy of this. The approaches that we were via the lamina terminalis or the interoptic corridor, but the problem was the chiasma in this patient. It was prefixed and it was posterior. It was prefixed and we could not go through the interoptic corridor. So we had to apply. We tried to go through the lamina terminalis only after decompression. This is the MRI of this patient, which reveals the T2 hyperintense lesion, lifting the third ventricle upwards. Basically, here we can see that this is a lesion which is perpendicular upward, and then the lesion which is of variable. This is a lesion of variable intensity just below the optic chiasma. Our goal was to decompress the lesion and to remove the solid part. So the steps we followed were frontotemporo-occipital orbital zygomatic approach. The patient was positioned in like this. We took a right transverse incision in the parietal region with craniotomy done. This is basically how I'm going to show the presentation, and this is how we actually approach the patient. After removing the flap, this is where we approach, and the important structure that I'll be showing here, which is going to be difficult to delineate in the video, meningoorbital band. This was incised. Post craniotomy, this is how it looked. This is the meningoorbital band in this region, and this is the eyeball after removal of the orbital part. This is, we are cutting the meningoorbital band. After this, we did anterior clinoidectomy using diamond bar hole. The anterior clinoid was removed. Here we are doing the durotomy, and post durotomy we did the trans-Sylvian approach via the Sylvian fissure going lateral to medial. We tried to approach to the optic chiasma. Basically, this is the part that I want to show. The optic chiasma, the carotid coming. We tried to go through the lamina terminalis. Initially, we could not go. We decompressed below the optic chiasma first, allowing the lamina terminalis to be visualized. Then we went through the lamina terminalis, eventually removing the tumor below the chiasma, and through the lamina terminalis we did the decompression. This is at the end of the surgery. Thank you.
Good morning. We'd like to describe intraventricular meningioma. This is a 37-year-old lady who had who did not have any deficits, presented with headache and visual blurring. You can see a lateral ventricular meningioma at the vessel, and we positioned the patient prone. These were multiple retractors which have been described for the same. We started off with a transsulcal approach through the superior parietal lobule, and we used image guidance to confirm the position at the trigone, and we can see that the tumor is being exposed. We used a single Laylas retractor and dynamic retraction. In this case, we did not end up using any of the circular retractors that were shown earlier. The surface of the tumor is being coagulated, and as you can see, we've approached the meningioma. We've taken bits for biopsy from this one. And as you can see, a small transsulcal corridor can be effectively utilized with the use of dynamic retraction and a single fixed Laylas retractor. After coagulation of the capsule of the tumor and incising the capsule, we use QSA to suck out the remaining, to internally decompress the tumor. And after internal decompression, we dissect the tumor from the walls of the lateral ventricle. Most medial attachments are released at last. The tumor comes out in toto. We check for hemostasis and then we place an external drain into the cavity. These are the silicone tubes or a 10 ml syringe tube or a 5 ml tube, all of which have been described for ventricular access and for retraction. But however, using a single retractor and the use of dynamic retraction prevents damage to the surrounding structures more than this. This is a post-op scan which shows no recurrence. The patient had a grade 1 fibroblastic meningioma, which and is doing fine. Thank you.
Good morning to all and all present here. So I'll be presenting on the distal azygous AIIMS, which was operated by Professor Suri. We had our patient was a 50-year-old female who presented with an ictus on 31st of January. She presented with no deficits, and as the scan shows, she had a distal azygous AIIMS. We had both the A2s which are being which we're using to form a single azygous ACA. So this is the DSA 3D reconstruction, which shows that the aneurysm was erected superiorly and laterally. We carried out a parasagittal craniotomy, following which we did an interhemispheric approach. So we identified the pericallosal artery, and we followed it anteriorly in order to identify where the pericallosal arteries, in order to find the gene of the corpus callosum. Following the same, we identified the aneurysm. So here, as you can see, the bilateral pericallosal arteries were identified, and they were followed entirely anteriorly up to the gene of corpus callosum. Following which, here, as you can see, we identified the darker aneurysm. So our next step was to ensure that we control both the proximal as well as the distal vascular system, so that when we finally dissect the neck of the aneurysm, we wouldn't have any problem. So here we're carrying out dissection and mobilizing the proximal and distal vasculature. So here we've mostly dissected the ACAs anteriorly, the A2 segments, and we have placed clips bilaterally. Temporary clipping was done for the bilateral A2 ACAs and also distally as well. Following the same, we then started dissecting. There was a hematoma as well, so we evacuated the hematoma so that we could create more space in order to adequately dissect the neck of the aneurysm. Following which, we decompressed the aneurysm, and after this, we did a water bath coagulation of the aneurysm in order to ensure that we were able to adequately put the wall and reconstruct the aneurysm as well. So in this case, we reconstructed the entire aneurysm using two angled clips bilaterally, and centrally we placed a straight clip as well, so that there was adequate vessel flow. Following the same, we did an ICG, and that showed that the proximal and distal flow was normal and not affected, while the aneurysm was completely occluded. So here, as you can see, we placed two angle clips on either side and a single straight clip in the center. Following the same, we ensured that there was adequate hemostasis. We removed the temporary clip. The total clipping time in this entire surgery was around 5 minutes. Following the same, we ensured that there was adequate hemostasis, and then we did a closure. So this is the post-op scan, which shows that there was a good post-op scan, and the patient went home on post-op day 4 with no deficits. Thank you.
You can leave one seat between each other, so you'll have more spacing. You can breathe more oxygen without the virus. There are a lot of seats empty in the hall. पांच लोगों का बिल जिनको डर होते ये ना
A very warm good morning to all of you. In a while, we will be proceeding for the inauguration ceremony. We have another studio, studio number 3. A few of the delegates can shift to that studio. It is on the right side of this room. Alternate seats, sir. Okay. Very warm good morning to all of you, and we welcome our guests to this conference. That it is indeed a pleasure to welcome you all on behalf of the organizing committee of the AIIMS annual Microneurosurgery workshop. This workshop has been the signature event of this department, and we always look forward to this event for the year. So, without taking much time, I would like to initiate the proceedings of the inauguration. I would like to invite our residents to present the bouquet to this chief guest, Professor Ranjit Guleria. Dr. Archana, please. Now I would like to invite Dr. Archana to present bouquet to our guest of honor, Professor Andy Verma, ma'am. Please. Dr. Archana, please stay and please present a bouquet to Dr. Professor Khalid, sir. And the final bouquet to Dr. Vivek Tanan, sir. Now I would like to request all the dignitaries to proceed for the lamp lighting ceremony. Sir. Now I would like like to request Professor Kale sir for the formal welcome address. Good morning, everybody. Professor Guleria, Director, All India Institute of Medical Sciences, Professor Padma, Chief Neurosciences Center, my faculty colleagues from the department, residents, fellows, and all our delegates from outside, all other people present in the auditorium. A very warm welcome to all of you for showing up today. It's a difficult time. It's a what can I say? It's a brave decision to come here, and on our part, it was a brave decision to go ahead with this. Till day before yesterday, we were deliberating whether to go ahead or not. Really, whether to cancel it or just go ahead with the online orations and not have this workshop. But we decided to go ahead with it because a lot of effort was put in by Dr. Vivek Tandon and the whole team. But one request to all of you is first to please switch off your mobiles or please put them on silent. Second request is to please comply with the instructions because we are going to make sure not more than 15-20 people are in each studio. So right now we have a lot of people here, but we're going to distribute you. So you may not be able to see the speaker live, you may be seeing a screen. You may be seeing the proceedings on a screen. So please comply with it. It's for your safety and our safety. So this is a hybrid event. Some of the audience is going to be online. Some of them are going to watch the orations on YouTube. The speakers are going to be online. Professor Sarvadei, who is going to deliver the Sarveshwari oration. What a coincidence. Sarvadei, Sarveshwari. Anyway, so he's going to be online from Milan, Italy. And the other speaker for P.N. Tandon oration, he's going to present from here, but the audience will be online. So the workshop stations are distributed across 3 rooms. The times are staggered. One batch is today, one batch is tomorrow, one batch will be on the last day, etc., etc. Please comply with all instructions. I request you, this is a new thing, a hybrid event. We haven't done this before, so I hope you enjoy these 2.5 days. And for all of the risks we have taken and you have taken, I hope this event is worth all the trouble which we have taken. Thank you and welcome you all once again. Thank you, sir, for those words. Now I would like to request Professor Andy Padma ma'am to say a few words of encouragement.
Thank you, and good morning, sir, friends, colleagues. It's so well spoken by Dr. Kale. It's really, I'm so proud on behalf of the center that the neurosurgeons, my neurosurgeons, have gone ahead and taken up this challenge. It's like the bravest amongst the brave. And I think this is the first time that this kind of a skill lab and hybrid is being. And I requested Vivek, in fact, to put this down in paper and publish it. This is the first time, probably internationally, you're doing this. And as Dr. Kale said, while the second wave is rising and a mounting challenge, you put together this, and I'm sure this is going to be a resounding success because of, I guess, there has been a micromanagement in this microneurosurgery. He's taken care of what he's been saying. And in fact, I would request you to patent what you've developed now, seriously, including that bowl which you just showed. And this is besides wishing you tremendous success, which I'm absolutely sure. God bless. Really proud of you all. Thank you.
Thank you, ma'am, for those words. Now I would like to invite Professor Ranjit Guleria sir to say a few words. Thank you and good morning, Professor Padma, Professor Kale, Professor Tandon, my faculty colleagues, residents, delegates, ladies and gentlemen. As Professor Padma said, let me congratulate the CN Center and the Department of Neurosurgery for this brave decision. I think it's the desire for academic activity was more than the fear of the pandemic, if I put it that way. And that's why the department went ahead and held the 23rd
annual microsurgery workshop, because there is a lot of passion in all of our faculty, especially in the surgical departments, of really holding workshops, being able to teach. So that's ingrained very much in our sort of DNA, if I put it that way. And that's basically because of the forefathers. Even if you talk of neurosurgery, this microsurgery workshop was the brainchild of Professor Banerjee, Professor P.N. Tandon, Professor V.S. Mehta, with the desire that they should be able to have surgeries visualized by students, residents, and other faculty to be able to sort of improve their skills. And this now has become a much sought after annual affair, which is a big sort of feather in the cap for the Department of Neurosurgery. And I think most neurosurgeons look forward for this event because of its uniqueness. And like I said, the department therefore decided to go ahead uh, despite the rising number of cases as far as COVID-19 is concerned. And I personally feel it's important because, like all specialties, there has been a huge evolution in neurosurgery in terms of training, in terms of technique. And most people feel that to know something, they have to see it. And to see it, you need to have workshops like this to be able to be confident that you can do it. And the hybrid model that is being looked at, didactic lectures, simulations, some degree of live workshops, is basically an attempt for absorption of what you will see today and self-reflection. And I think it's a chain event. You watch, you sort of reflect, question it, and then you try it out on simulators and get the confidence that you can do it. And that is what this hybrid model is all about. It's a big challenge considering the current situation. Physical distancing, the fear of COVID-19. I was wondering whether Dr. Kale had put in a rider to all the delegates that you must carry a COVID negative RT-PCR report before you can enter. It could have been possible that you could have done that.
Either that or the vaccine.
Or the vaccination. So these are challenging times for all of us. But at the same time, all of us feel that we must continue with our academic activities, especially because residents are an ongoing group. They can't stop in time and wait for the pandemic to be over and then start their training. Therefore, I'd like to just congratulate the department for this microneurosurgery workshop, which I know has been something they're very proud of, and they've put in a lot of effort, especially this year, because of the challenges that they faced. And like Dr. Padma said, this could be some sort of a model which could be presented, published, and adopted by other institutes as to how to do such a workshop. So congratulations to the whole team. Thank you very much. Thank you, sir, for blessing us and those words of encouragement and motivation. Now I would like to call upon Dr. Vivek Tandon for to give a vote of thanks.
Thank you, sir. I would like to thank our director, Professor Guleria, our chief, Professor Padma, Professor Kale, and I'm telling you, without their guidance and support, this wouldn't have been possible. 2 days back, as Professor Kale rightly said, he was considering, whether we should call it off or not. But thanks to their guidance, we are still holding it. I would also like to thank our senior faculty members, Professor Chandra, Professor Suri, who has been very supportive and has allowed the delegates to participate in the anastomosis workshop in his lab, Professor Manmohan and Dr. Ravinder. And I would also like to thank all our junior colleagues and my fellow colleagues, including Dr. Shashwat, who is the co-organizing secretary and has been the backbone of support for me. Dr. Kavanjit, Amol, Satish, and everyone who is sitting here, Dr. Shweta, Dr. Borkar, Rajesh, Ramesh, Aman, everyone. I would also like to thank our ancillary departments of Department of Neuroradiology, Professor Gaikwad, Professor Chaturvedi from Neuroanesthesia, Dr. Sharma from neuropathology, Dr. Jayal from physiology, and all our neurology colleagues also to be helping and supporting us. I would also like to thank all our students. I thought that maybe they won't be so enthusiastic, but the participation has been very enthusiastic. At 8 o'clock, this hall was practically full, and they started presenting. And each and every student of our department is doing something, presenting something, doing some research during the course of this workshop. Everyone is involved. And a lot of effort has been taken up by some of the chief residents, like Dr. Ravi, Devashish, Varid, everyone, to hold this. To thank our paramedical staff from our operation rooms, wards, animal labs, who have been very supportive in this, especially the animal lab and the operating room staff. Our clerical staff, Mr. Vipin, Ruth Narayan, and everybody who is there in the office. And all our sponsors, because without their support, this is simply not possible. And with these kind words, I would like to welcome all the delegates. And this workshop is meant for the sake of all of you. And we expect that you deliberate. And the motto is engage, learn, and grow. So you engage with the faculty whosoever is there. And if you have an idea, you discuss. And that's the model that we have been following. There are multiple rooms here. All of you cannot sit in one single room. You can sit in different rooms, and each room will have a different set of things that will be happening. So whichever faculty is there, whatever small question that you have, you keep on asking. With discussion, you will learn. With engagement, you will grow. That's what the motto of this whole workshop is. And with this, I would like to thank everyone and welcome you all to this tea that we have in the cafeteria. Some of us can walk there, and then maybe later the rest of you can come. Thank you. No, you don't require streaming link here because we want you to be attending physically. The streaming link is when this hall gets full, I mean, you stream it to the next hall. So, surgery we cannot show on YouTube because of ethical reasons. I mean, what if something goes because only 10 people will be here, it is difficult. So what we have planned is a very innovative kind of a thing. In live surgery, there will be time when somebody is moving microscope, time is wasted, patient is getting induced, again time is wasted. And we'll encourage you to discuss. So like on the length of surgery. And he will be telling you each and every step. And we will request you to ask questions from him. What if I do it differently? Why are you holding the knife? Dr. Francisco Prada from Italy. Okay. So those of you who are there, who are free, I mean, you can just walk in here and you can listen to the talk. Okay. हम्म पढ़ाओ ना तुम कोई प्रॉब्लम नहीं आओ ना. Now just sit down for 5 minutes. We are waiting for everybody. We will start at 10 o'clock. There are a few housekeeping announcements that I want to make and show you so that you are clear what you have to do. Okay? Just sit down for 5 minutes. If you have any more friends and colleagues outside, please ask them to walk in so that I can explain so that you don't get confused where you have to go, what you have to do. For that is around 10 to 15 people can be there at one time. But due to what director has told you and the instructions that we received from him, we can only allow 5 persons at one time in the lab. Okay. So we thought that we'll finish off everything in one day, but unfortunately we cannot. And for the safety of all, what we have done is we have extended it for 3 days. Okay. So maybe last Friday or maybe Thursday, we had to stop the registration for the workshop because we realized that beyond 30 people, it will be very difficult to accommodate in the anastomosis workshop. So we stopped registrations then. So those of you who have registered before that online or physically, they are in the list for the anastomosis workshop. Rest of you who have registered after that, you are in the wait list. Okay. But I will request all of you to help each other out because all of you have come from such far-flung places and you are here to learn, and obviously you will meet again sometime later in life. So it's better to help each other out. You are already on that delegates group. You can take each other's numbers, and those who are going today, if they finish early, they can inform the next person who is the observer for today. So observer means he doesn't get a chance, but he can get a chance if you allow him to. Okay, so if you finish early, you are done with your anastomosis thing, you are tired, you just call up that person and inform Dr. Shashwat and Dr. Ramol, who will be in the anastomosis lab, and in the drilling lab, Dr. Shantanu will be there and Dr. Rajesh Meena will be there. So you can inform our faculty that, sir, we are done, and please ask the next person who is there in the waiting list to come and do this. Okay, and we hope that all of you will follow this protocol. Always wear the mask there. And here in SET facility, we have around 5 stations. Okay. So station 1 is serotactic planning and biopsy. So that planning and biopsy is in studio 3 here. So they have a robot which they have brought new thing, but all of you will not get the robot. So what you should learn on that station is how to plan. Our faculty, Dr. Deepak Gupta will be there and Dr. Shweta will be there. So you should learn how to plan, and maybe then the company person can show you the fanciful stuff, that is the robot, but learn how to plan. Then there is an ultrasound workshop that is there. It is a very useful modality. Intraoperative MRI is very expensive, but ultrasound is very good. So we have developed a simulation model for you. There is a bowl which has some berries inside, if you will go there. And Dr. Vared and Dr. Nidisha are there, who will be coordinating the effort, and you will be asked to localize the berry and you will be asked to insert a needle in the ultrasound guidance and take a biopsy from it. And there is a model for that. They will tell you when you are there. Then there is C1, C2 model. Dr. Borkar, once he is free, he will again teach you how to insert a C1, C2 screw. You can spend some time there. And then similarly, CUSA will be by Dr. Raji. He will tell you how to handle the CUSA and the intricacies of it. So you can spend some time there. Then there is station 5 and there is station 6. So station 5 is this hall. And station 6 is also this hall basically. I mean, you can take a break, have lunch, have some breakfast, tea, which will be going on for the whole of the day because we don't want crowding to happen there. But at the same time, whosoever is free, you can come here and sit because we'll be showing you, some of us will be showing you lectures and some of us will be showing you the unedited videos which we were talking about. So always there will be something or the other which will be going around this hall. And at 12:30 p.m., sir, there is a guy called Francisco Prada from Italy. He has agreed to take a talk on ultrasound. So that talk will be at 12:30 p.m. Those of you who are free, you can walk in here and have the talk, which will be zoomed live from there. Okay. So these are your workstations. And there are 6 batches for the SET facility. There is a batch A, B, C, D, E, and F. So all batches have got names of all the delegates. In case someone's name is missing, Dr. Devashish is there. He's also in that WhatsApp group which I have created. So you can meet Dr. Devashish. He will help you out. Okay, your name will be somewhere. He will put it. And Devashish, you can put this on Google Sheets and you can continuously keep on updating this sheet. Okay. And this is the schedule for the animal lab. For the first 5 people will be doing the anastomosis in the morning session and then they will be doing the drilling. And then there are 2 people who are observers. So if someone amongst you is done, he can call the observer and then he gets the chance to do it. In case the observer doesn't get the chance to do it on today, and similarly there is a list for tomorrow, the observers so there are 8 observers practically. So if they don't get a chance to do it on 18th and 19th, the observers get the chance to do it on 20th, which is the Saturday. But we hope that all of you can do it between 18th and 19th. So people who are in the wait list who have not been selected here, they can also do it on the 20th. Okay. So the first talk here will be by Professor Kale. You can check out your groups, and Dr. Devashish has it. All the information has been relayed to you on your WhatsApp group. So first talk will be by Professor Kale, and then Dr. Borkar will take over and he will show you some of the videos. Okay. And similarly for lunch, I mean, just don't rush there every time. It will be kept from 12:30 to 3:30. No problem. It's a packed lunch which will be served, not a buffet lunch. So you can just have the lunch in the cafeteria. No water bottle, no nothing which can be eaten is allowed inside the whatever is there in the cafeteria. कनेक्ट नहीं किया ना तो वो सारी करते जाना उन्होंने बोला है कि इसको लिख के पब्लिश करना पेपर में there is no link for it. Okay. You can come here. Or there is a YouTube link. Let me send you this. Maybe if you are from the West, you can listen to it on YouTube. Okay, so how many people are here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Okay. So spread yourselves out, maintain distancing, don't sit close together. There's enough space for 20 people to have distancing over here. So this is going to be a very basic lecture, and it's going to be on spine. So even if you're not interested in spine, just listen to it because I think it will be useful. Some basic concepts which you need to know about spine surgery. So we have about 20 odd people, and how many of you are from outside AIIMS? Everybody? Oh, almost everybody. So you're not in any workshop today, I suppose, not in any of the stations, other stations. Half an hour later. Okay, so this won't take much time. And so let's not waste time, otherwise I would have asked for an introduction. So this is going to be about the biomechanical anatomy. You know, you might have read about anatomy in your first MBBS and read maybe later about the anatomy, what are the muscles attached, ligaments, etc., etc. But you must know the biomechanical anatomy of the spine before you start operating. So let's see, what is the meaning of spine? What all does it include? When you say a spine lesion, it could be a lesion of any of these entities mentioned here. It's the vertebral bodies, the intervening discs, and the various parts of the vertebral body. That is the pedicle, the lamina, the facet joint, the spinous processes, and the muscles and ligaments which are attached to these bony prominences. So all of these are included when you say spine. So you must know about all of these before you start operating on spine. It's not just enough to know the shape of a body or the parts of a body. You must know about all these things. So let's start with the body.
So, can I have a pointer? Is there a pointer? Very good. So if you see the vertebral bodies of the whole spine starting from above, below, the width and the depth, they increase from rostral to caudal. So if you see, this is a chart and it's been taken from a book by Dr. Benzel. It's called Biomechanics of the Spine. And the first chapter of that book, I think it is about all this. So if you have that book, please read it. If you don't have that book, I think it's available online, and he has made it free for AAINS members. So if anyone of you is a AAINS member, you can get that book free, at least the online version. So it's a very simple but a very nice chart which shows you what happens to the width and depth as you go down the cervical spine to the thoracic and to the lumbar. So this is an important thing to remember, because many times you overlook the forest for the trees. You're looking at individual vertebrae, but you don't know what is happening in the whole spine. So what is happening in the whole spine is that the width and the depth keep on increasing as you go down the cervical spine. And what do you mean by width and the depth? This is the depth, anterior, posterior, and this is the width from right to left. The depth, that is the anterior posterior dimension of the vertebral body, it starts to taper off at the lower end of the spine. At L4 and L5, it starts decreasing. So remember, L4 and L5 are actually less deep than the first three lumbar vertebrae. While in the cervical and the thoracic spine, it keeps on increasing. The width and the depth gradually increases. The height also increases rostral to caudal except at C6 and lower lumbar levels. Again, the height is not shown in this, but the height is the vertical height of the vertebral body, and that too increases in the cervical spine. It decreases at C6. So remember, C6 and C7 are actually smaller than C5 and C4. And the lower lumbar levels, again the height of L5 is smaller than that of L3. Remember that. So this is what is meant by the height. This is the height. And there are two heights you should remember. That is the ventral height and the dorsal height. Because it is important to know what is happening. Because if you don't know this fact, you will think that there is a collapse. That the anterior height is lower, that means there has been a collapse. But that's not true. For the lower lumbar vertebra, there is a difference between the ventral and the dorsal heights. Can you see that? The dorsal height is lesser as compared to the ventral height. So they already are wedge-shaped, the lower lumbar vertebra. You must remember that. Again, this height, it decreases in the cervical spine up to C6 and then gradually increases up to the lower lumbar level, and L4 and L5, there is a divergence between the anterior and posterior or ventral and dorsal height of the vertebral body. In the cervical spine, another important pearl you should remember is the uncinate process. What is the uncinate process? I'm sure when I was a resident, I did not understand what is uncinate process. It was difficult to imagine, especially during surgery, where is the uncinate process. So if you look at this picture, this projection of bone, it is a schematic version, so it is shown bigger than what it actually is. It's not as big as this. But this is where the uncinate process is. So this is the posterior elements of the vertebra. This is the spinous process. These are the facets, superior facet, inferior facet. And medial to the superior facet is the uncinate process. And the important thing about the uncinate process is it's very close to the artery. It is very close to the artery. So if you damage or if you are close to the uncinate process, you may damage the artery. So you have to be very careful about, and the root, both of them are close by. Here they have shown the root coming out of the intervertebral foramen. And this articulates with the caudal, dorsal and lateral aspect of the body above. So the body above sits here and this process articulates with the body above. So that is why whenever you are doing a corpectomy, you must know where is the uncinate process and whether you are close to the uncinate process or not. If you make too wide a corpectomy, you are likely to damage the uncinate process and to damage the root. So you must remember where is the uncinate process. And these uncinate processes are part of the oncovertebral joint. So onco is a short form for uncinate process. So oncovertebral joint means the joint formed by these uncinate processes. Now, shape of the vertebral body, generally it's a solid cylinder, but the surface facing the spinal canal is concave. Do you see that? That's a concavity there. And it's good that it is concave, especially for the cervical spine, because if you see this, if you're putting an anterior cervical plate which is going to rest over here and the screws are going to go into the body here, you can see here. This shape of the concavity gives you that extra 2 or 3 millimeters to get a bicortical purchase. You can get a purchase in the distal cortex also and still not impinge on the dura or the contents of the spinal canal because of the shape. So there is this 2 millimeter gap, and that allows you to do a bicortical fixation. And a bicortical fixation means you engage with the screw this cortex and the cortex near the spinal canal. So if your screw is engaging both the cortices, it is going to be a stronger screw. The pull-out strength is going to be much higher. In earlier times, when there was no locking mechanism for the plates, when I was a resident, all these locking mechanisms were not available. So the only way to lock or to make sure that the screw pull-out strength is adequate is to take a bicortical purchase. So if you engage both cortices, it's going to be stronger and safer. And that is helped by this peculiar shape which gives you that 2 or 3 millimeters, which is enough to get a bicortical purchase. So even if the screw tip is projecting a little bit inside, it's safe, especially in the cervical spine. It's not going to do much damage. Now a little bit about physics. You know what vectors are. Vectors have a quantity as well as a direction. So a vector means there has to be a direction to it. So at any point in the spine or in the vertebral body, the forces which act can be treated as vectors acting on a particular point. And you know there are 6 degrees of freedom around a point, 360 degrees. So a force vector may act on a lever, and that lever, when it is acting from a distance, force acting from a distance on a point is a lever. So a lever, whenever it acts on a point, it causes a bending moment. It either lifts or it depresses or it moves to the right or the left, depending upon from where the vector or direction of the vector which is acting. So remember that, because this concept of vectors and where the force is being applied and what movement is occurring at that particular point is important to understand the nature of injuries to the spine, what kind of fractures. You won't understand it till you understand where is the force coming from and what is the vector and what is the moment which the vector is producing. So it is important to understand all this. So a bending moment to a point can be in 3, the X, Y, Z axis. So if you take the X axis, it can be in 2 directions, this way or that way, similarly for the Y and similarly for the Z. So for any given point, there are these 6 degrees of movement which are possible. So you must know where the force is acting on it. I mean, if a person falls on his head, so where is the force going? What is the vector? What is the moment it is producing? Unless you understand that, you won't know. A whiplash injury, there is his head strikes against something and then goes back. Where is the force? It is coming from anterior. What is happening at the the point where these vectors act is this IAR, the instantaneous axis of rotation. Usually it is close to the center of gravity of that vertebral body, and that point which is close to the center of gravity is the point where all these forces act, or close to that. So the instantaneous axis of rotation is important. You must know where is the IAR in the spine so that you know where this force is going to act. For example, in a straight spine, if there is no curvature of the spine, the instantaneous axis of rotation is right at the center of gravity of the vertebral body. So you know in a straight spine, the movement is going to be centered around this point. But if there is kyphosis in the spine, whenever it is kyphosed, the instantaneous axis of rotation is going to go close to the spinal canal. It's going to move backwards. And that's why in thoracic spine, the injury is much more devastating because the thoracic spine is kyphotic and the instantaneous axis of rotation is close to the canal. And if there is an injury and a fracture, the portion of that bone is going to hit the spinal canal and the cord. While the cervical spine is lordotic, the instantaneous axis of rotation is closer to the anterior surface, and that's why the injuries in the cervical spine and lumbar spine are safer, if you just go by the shape of the spine. While in the thoracic spine, it is more dangerous because the IAR is close to the spinal canal. So that is one of the reasons why thoracic spine injuries are devastating, because it causes more trauma to the spinal canal than the cervical and the lumbar spine. Another good thing about the lumbar spine is that the spinal cord ends at L1. After that, it's only the roots. Anyway, so, and the second important use of this is your instrumentation. Because when you want to fix, you must know where the instantaneous axis of rotation is. Because your fusion is, if the spine is kyphotic, you instantly know that you need to correct this kyphosis before you can fuse. Otherwise, your forces are not going to act where you want. They're going to act closer to the spinal canal. And if your plate fails, this thing is going to get pushed behind and it's going to fail. So you must know where the instantaneous axis of rotation is in a kyphotic spine, in a lordotic spine, in a straight spine. So the important thing to remember is, in a kyphotic spine, the IAR is close to the canal, while in a lordotic spine, the IAR is close to the surface, to the skin. Now let's see the anatomy of the facet joints. It's important because these are the joints which contribute a lot to the stability of the spine. For that, you must know the orientation of the facets. If you see the cervical spine, the orientation of the facet is like this, as if you are blessing somebody. Remember that. Remember this. Get this picture fixed in your head. The facets in the cervical spine are like this, and the lower facets are like this, and that's why one facet rests on the other. The shape is like this. If you look at the thoracic spine, it's like this. The facets are facing medially. If you see that picture, in fact, it's facing medially, but laterally they're outwards, medially they're inside. The second picture, labeled B. And in the lumbar spine, they're facing outwards. You see the facets of the lumbar spine, they're facing outwards, not inwards. Remember that. So unless you know this, you wouldn't know which is going to slip. So with this configuration, you instantly know that this is an unstable region because it's just resting like this and it's going to slip either forwards or backwards. And that's why dislocations are much more common in the cervical spine, because the facets don't stop this movement at all. And that's because of the orientation. So you must remember, cervical spine facets are this way, the thoracic spine facets are this way, and the lumbar spine facets are just the opposite. They're facing outwards. Do you see that? They face this way. Thoracic spine is this way, and cervical spine is this way. So what is the use of this? So when the facet joint takes partly the load of the whole spine, whatever is being loaded onto the spine, the force is transmitted through these facet joints, partly through these facet joints to the next vertebra, and then to the next vertebra. They support axial loads, but as I will show you in the next picture, the cervical spine, the facet joints come into close contact only in extension. If you flex the spine, the facet joints move away from each other. And that is why whenever you have to fix the cervical spine, you have to make sure that it is in extension. Otherwise, it's not, the whole load is going to be borne by your construct, that is the plate or the graft anteriorly. Facet joints will not bear any load if you fix the spine in a kyphotic position. You have to make it extended so that the facet joints touch each other. And you can see this on an X-ray inside the operating room. So if you don't get that extension, your construct is in danger of failing. You have to make sure that the facet joints are opposing each other. because only then they touch each other, then the load is transferred. The rest is okay. So because of the orientation, you see what the orientation of the lower lumbar facets is. It's nearly coronal, so that the listhesis is less here. In the L5S1, the joints don't move at all. They don't move at all. Hardly any movement, just a few millimeters. And in the lumbar spine, it gradually starts increasing, while the axial rotation goes down completely. So there is hardly any rotation in the lumbar spine, while there is some flexion extension movement in the lumbar spine. Canal and contents, I need not to go about the neurology of it. So you see the pedicles. What happens to the pedicles? Because if you want to put a pedicle screw, you must know what is the anatomy of the pedicles. So in the cervical spine, they are short, they are proportionally greater diameter. They're short, but they are wider. The diameter is more in proportion to the size. Not that the cervical pedicles are wider than the lumbar, they're not. But in proportion to the size of the vertebra, the diameter of the pedicles is wider in the cervical spine. The transverse width gradually decreases, cervical to mid-thoracic, and then increases in the lumbar spine. So the width is this. This is important to know because that's where your screw is going to be if you want to put a pedicle screw. So you must know the width. If you see the width of the cervical spine pedicles is about 5 to 7 millimeters. That's all. It increases gradually from C3, 4 right up to T1. It's about 5 to 7 millimeters. Then in the thoracic spine, it actually decreases. In the mid-thoracic spine, it's back to 5 millimeters only. And then it gradually increases. And in the lumbar spine, there you have big pedicles, wide pedicles, up to 17, 18 millimeters in the L5 and S1. So 17 millimeters is a big space. You can put a 4 mm screw very easily. You can triangulate it, you can put it up, down, whatever. So you have much more space in the lower lumbar as compared to the cervical pedicles. Height of the pedicle, this is the height of the pedicle. Again, the height in the cervical spine is just a few millimeters, maybe 7. In the thoracic spine, it starts increasing. And in the lumbar spine, the height is really up to 18 millimeters, it can be in the upper lumbar vertebra. Those are wide pedicles. So what it means is you can direct the screw downwards, upwards. You can play around with the kind of force you want to exert by putting the rod on top of the screw. So if you have the correct direction of the screw, you can put some forces so that you either distract or you compress, depending on what you want to do. But all that is possible in the lumbar spine, or maybe to an extent in the thoracic spine. But you cannot do that in the cervical spine because the height of the pedicle is just 6, 7. And if your screw is 4 millimeters wide, there's hardly any space. So you can't manipulate in the cervical spine. Next is the angle at which the pedicles are attached. You must know which way the pedicles are attached. If you see in the cervical spine, they are almost 40-degree angles. So they are directed medially, almost 40 degrees medially, the pedicles. And in the thoracic spine, in the lower thoracic spine, it is 0. That means the pedicles are straight. So your screw has to go straight. In the cervical spine, it has to go medial. And in the lumbar spine, again, the mediality starts happening. While in the last lumbar vertebra, it may be up to 30 degrees medial. So the last lumbar vertebra, L5, the screw has to be directed medially almost 30 degrees. So remember that. Cervical spine is the highest. Thoracic spine, the lower thoracic spine is almost 0, straight. And lumbar spine, again, you need to be medial. Next is the vertical angle. How the pedicle is attached to the vertebra, the height of the pedicle. If you see in the thoracic spine, the pedicle is higher than the body. So whenever you're putting a screw in the thoracic spine, the screw has to be directed downwards towards the lumbar region. While in the cervical spine, it is -5. That means the body is higher than the pedicle. So your pedicle has to be directed upwards. The screw has to be directed upwards. So your pedicle screw in the cervical spine has to be 40 degrees medial and about 10 degrees or 7, 8 degrees upwards. So this is the direction, up and medial. While in the thoracic spine, it is straight, 0 degree. You don't have to go medial or lateral, 0 degree. In the lumbar spine, again, it starts dropping the height at which it is, the angle at which it is attached. And again, in L5S1, it's almost zero. So again, you don't have to put it below or above, you have to put it straight for L5S1. It's almost 0 degrees. So entry points, there is no point discussing this because this is a separate talk by itself, but there are a lot of books available and all kinds of landmarks are available. One of them is shown over here. But remember, the basic way of finding out where the pedicle begins is two landmarks, the facet and the transverse process. And the whole thing is to find out the entry point is identifying the facet, which is this, and identifying the transverse process, which is this. And if you remember the lumbar spine, you draw a line in the middle of the transverse process like this. You draw a line from the outside of the facet like this, and approximately where these two lines meet is your entry point for the pedicle. And this holds true for most of the lumbar vertebrae. In the thoracic vertebra, it is a little bit different because if you go outside the pedicle, outside the facet and bisect the transverse process, then you may be slightly lateral. And in the lower thoracic vertebra, your entry point will be slightly lateral and inferior. So you have to make those adjustments depending upon the level of the vertebra you are in. You know about the biomechanics of the disc. As you bend laterally, the nucleus pulposus shifts to the other side. And if there is compression, it may propel the nucleus pulposus backwards or forwards. And that's why the disc prolapses occur. Depending upon what force has been applied, the disc may either prolapse to the side or to the side and anterior or completely anterior. That determines whether the disc is going to be central or is going to be to one side or is going to be extremely lateral near the foramen. Here is a picture which shows what happens. So the nucleus moves in the opposite direction. So if there is compression anteriorly, it's going to force the disc to go inside the spinal canal, and that's where disc prolapses occur. You must know what are the transverse processes. They attach all the paraspinal muscles. So whenever you are denuding the transverse process of all the muscular attachments, you are inherently making it unstable. You have to be very careful when you bear the transverse process. And the paraspinal muscle attachment is giving you the leverage for lateral bending. So you're going to compromise. The moment you bear everything, you're going to compromise because you have taken off all the ligaments and the muscle attachments. Usually they are small, they are easily fractured, they have poor vascularity. But in the lower thoracic spine, they are good sized, but they are pointed laterally and upwards. If you have dissected the thoracic spine from the back, you would know that the transverse processes start rising. They come towards the surgeon. The transverse process rises up like this and it's pointed upwards. In the lumbar spine, they are much more ventral. They are more deep inside. So to get to the transverse process in the lumbar spine, you have to really make a paravertebral dissection to take off all the muscle and to identify the transverse process. And in the C1 to C6, remember the transverse process is very close to the foramen which carries the vertebral artery. So getting the transverse process in the cervical spine is tricky because if you're dissecting between two transverse processes, you will damage the artery. These are the various ligaments which are attached: the anterior longitudinal ligament, the posterior longitudinal ligament, the intertransverse ligament, the ligamentum flavum, the interspinous ligament, the supraspinous ligament, and very important is the facet capsular ligament. That is the ligament which surrounds the joint, the facet joint. And if you see the failure strength, how much strength is required to tear all these ligaments? And if you see which ligament has the maximum failure strength in the lumbar spine, of course the ligaments and the bodies and everything is bigger. But out of all in a particular region, the strongest ligament is the ALL, the solid black one. It has got the maximum strength. Which is the second? The one with hashes, diagonal hashes, and that is the PLL. So the PLL is important, the ALL is important, and the third one is the capsular ligament. So if you dissect all the ligaments of the facet joints, this is dangerous thing. So you should avoid taking a bipolar or a unipolar and just scraping off everything till you see nice shiny bone, especially for facet joint. And this is important in lateral mass screw fixation of the cervical spine, because you tend to just take the monopolar and scrape off everything till you see the facets clearly. But the moment you take off the capsular ligament, as you can see, a strong pillar of support to the spine has been demolished. So the dissection, you should dissect it with a cob periosteal elevator, so that you don't damage the ligament. It slips over the capsular ligament and it saves the ligament. So your dissection should not be with a monopolar, it should be with a cob. And why is it so? Why are these ligaments, if you remember the instantaneous axis of rotation, the vector, the longer the lever, the more the force it can exert. It's the famous Archimedes principle who said that give me a place to, which makes the spine straight. So if one fails, it's going to go in the other direction, because that other muscle is going to contract strongly. So if the psoas or rector abdominis are weak, the rectus spinae is going to act and the patient is going to be in extension. While if the rectus spinae, if you have dissected and destroyed all the muscle, then the psoas and the rectus abdominis are going to act and the patient is going to go into kyphosis. So you must remember not to damage the muscles. Generally in spinal surgery, you don't damage the flexors because they're too deep inside. But erector spinae is the one which is mostly damaged, and that's why if you do spine surgery, especially laminectomy, where you remove the bone and the muscles and the ligaments, the patient goes into kyphosis. He goes into kyphosis because of the action of psoas and rectus abdominis. You must know about the bone. Ratio of the cortical to cancellous bone affects the load bearing. So the more the cortical bone, the stronger your fixation is going to be. And the marrow, or the body of the vertebra, has all this cancellous bone inside. It's actually marrow. So any screw in the body is inherently weak. But the pedicle has a lot of cortical bone and very little marrow. So a cortical screw is very strong because it is engaging the cortical bone, which is much stronger. You must know that the pedicles have the maximum ratio of cortical to cancellous bone. And that's why pedicle screws are stronger. While if you put a plate on the body, which is the anterior cervical plate, it's not as strong as a pedicle screw because it's going into the body, which is cancellous bone. So the bone density correlates with the screw pull-out resistance. So that's why you must try and put pedicle screws if possible, because they are the strongest. Osteoporosis decreases this density by 50%, and 50% loss of bone actually results in 75% loss in strength. So it's not a one-to-one relationship of calcium and strength. The loss in calcium relates to much larger loss in strength. So you must be very careful about operating in osteoporotic bone. Here is a picture which shows you what happens in extension. This is what happens in flexion. If you can see, all the facet joints are separated. And this is what happens in extension. All the facet joints touch each other. And when they touch, the load is borne by the facet joints and transmitted downwards. While if you fix the spine in this, all this construct is not contributing to your load bearing at all. And if you put a plate in front, the whole load of the head and everything above is going to be taken by the plate and it's going to fail. While if you fuse it in extension, partly the load is going to be shared by the posterior elements and your construct may be safe. So remember, always fuse the cervical spine in extension. The erector spinae ligaments and all those ligaments, they provide a very good tension band. So remember, try and not destroy that midline tension band, because that is responsible for keeping the spine in extension. And sometimes subluxation can be easily treated just by recreating the tension band. You just put the spinous processes together and recreate the tension band, and that will do the trick. Earlier times, this used to be the method of treatment. So thoracic spine, there's very little movement. We saw the whole anatomy of the bones and the ligaments. And it is shielded by the massive muscle mass and thoracic cage. There is this thoracic cage. So all the vertebrae are fixed to the sternum anteriorly. So there is inherent stability in the thoracic spine. But it's got a very narrow canal, and the shape, it's not like the cervical spine. It doesn't have that bean shape. And it is in kyphosis. So the instantaneous axis of rotation is near the spinal canal. All these factors contribute to catastrophic results of injury to the thoracic spine. So if you see thoracic fractures, they lead to paraplegia very easily, very easily. So thoracolumbar junctions, you must remember all these junctional areas where the cervical lordosis and the thoracic kyphosis, where these two meet, the junctional areas are the most vulnerable. So the cervicothoracic junction is vulnerable. The thoracolumbar junction is vulnerable. The lumbosacral junction is vulnerable. All these are vulnerable areas. So if you're doing a fusion and somehow you have to stop at C7, you shouldn't stop at a junction. You should cross into the thoracic spine and take 1 or 2 levels of the thoracic spine as well. If you're fusing the thoracolumbar area, you must not stop at T12. You must go down to L2. Except maybe in the sacrum, because the sacrum is a very big solid bone. So you may stop at S1. Ideally, for L5, S1 reduction and listhesis and all that, you should have 2 anchor points in S1. Either you have S1 and S2, or you have Euler screws, so that you have more stability. Lumbar spine is, there is no cord here, so you are safe. It's all roots. So unless there is a damage inside the dural tube, most of the roots can escape injury. Lumbosacral junction I just told you about. So stability and instability. You must know this concept of stability and instability is important. So ability to displacement so as not to damage neurological structures. As you know, there is a lot of movement possible in the spine. For example, in C1, C2, there's 40-degree rotation possible, but it doesn't cause any injury. The moment you turn your head, you don't become unconscious or paralyzed. So that is physiological movement. So that much of instability is physiological. You should not worry about that. The dangerous movement is which causes neurological injury or compression. And so the clinical stability is important, not just you see some movement on X-ray, that doesn't mean that it is unstable. It should produce some damage, because if the patient can turn his head 40 degrees, that's normal. So if he can rotate even after your fusion, that's fine, doesn't matter. It should not go more than 40 degrees. So the concept of clinical stability is that it should not cause damage to neurological structures. As long as it is within this, it is stable, it is fine. But people have tried to classify stability and instability based upon a lot of things. This is a 3-column concept. You know, the Dennis gave it that there are 3 columns: anterior, middle, and posterior. And somebody else also gave a 2-column concept, that there is one anterior column in the front and the facet joint are 2, actually side by side there are 2 columns. So anterior-posterior, there are just 2 columns, but the posterior one is split into 2 halves. So that is a Lewis concept, while this is the typical ones which we generally talk about, the 3-column concept. And the good thing about the pedicle screw is, the pedicle screw, when it goes, it engages the posterior column, the middle column, and the anterior column. So it gives a 3-column support, and that's why the pedicle screws are much more stable, because all 3 columns are engaged. While if you just do a spinous process fusion, or an interlaminar fusion, or an interfacet fusion, it's not as stable as a pedicle screw, because it engages only 1 column, the posterior column. While a pedicle screw goes right into the body, so all 3 columns are engaged, and that's why it is more stable. Another important concept you must know is what is pass screw. Many times for C2, people use the concept that I put a pass screw. Well, somebody says I put a pedicle screw. What is the difference between the two? What is pass and what is pedicle? If you see the definition of pass, the full name of pass, can anybody tell me what is the full name, anatomical name of the pass? Yeah, somebody said that. Very good. So interarticularis, that is the area of bone which is between the facet above, articular facet above and below. That is the pars interarticularis. So if you see, this is the facet above, and the facet below is underneath here. So the area of bone between the two facets is the pars. It is much more lateral. While the pedicle is the one which joins the lateral mass to the body, or in this case of C2, to the small body of C2. So the pedicle is the bone between the facets, between the superior facet and the body. So that little bit is the pedicle. And this bigger bit between the facets above and below is the pars. So the pars screw is going to be more lateral, while the pedicle screw is going to be more medial. So operation wise, this is the difference. Your pedicle screw is going to be more medial, while the pars screw is going to be more lateral. It is going to be in the piece of bone between the facet above and the facet below. So remember the definition of pars interarticularis, you will understand what is the difference between pars and pedicle. Pars is between the two facets, pedicle joins the whole lateral complex with the body. So the pedicle is much more medial and the pars is much more lateral. So column concepts we have been through. So for White and Punjabi have given this definition of stability. A lot of things which actually contribute. They have given points, and you give points for everything. So more than 5, 2 to 4, there is limited instability, and more than 5 points. But it's too complicated. Nobody ever uses it. For theory, it is very good, but for practical purposes, it's the 3-column concept. So remember whether all 3 columns are injured or not. You see an MRI, you see an X-ray. Try to always imagine whether all 3 columns are, even if 2 columns out of 3 are injured, that means it is unstable. Rule of the thumb. So this is regarding listhesis. Limited instability, okay. Yeah. So you must know, instability is not just instantaneous like in a fracture or a dislocation. Instability is also in, say, something like listhesis. You see an 18-year-old with L5S1 listhesis, and that listhesis has been probably happening over the last many years. So the instability is a chronic glacial kind of an instability. Very slowly it is slipping forward, either because of some pedicle damage or lysis in the pedicle or some factors which are unknown. So not all instability is instantaneous because of a fracture or a dislocation. Instability can be a slow glacial progression, like the L5S1 instability. Okay, so I think we should end it now. I hope this you remember at least some parts of it, and next time you operate on the spine for any fixation or you are assisting somebody who is operating, you must try and apply some of these principles, and that will make your operations much more safe and sturdy. They won't fail. Otherwise, if you just put in screws on a plate, it is going to fail if you don't follow the principles of physics. Okay. So, any questions? No questions?
What's the difference between pars interarticularis and lateral mass? Both are same.
No, lateral mass is the whole thing. Lateral mass, the top part usually has the facet, the bottom part has the inferior facet. In cervical spine, it has the foramen. So that whole thing is called lateral mass. While facet is just one part, the superior part of the lateral mass, inferior part is the inferior facet. Between the two facets is the pars interarticularis. The whole thing together is called lateral mass. Clear all your doubts. It's a very good question. So because people are still confused about the anatomy. Multi-level degenerative anterior or posterior. Well, it's difficult to, you have to individualize to every patient, but remember 3 things. 3 things you must remember. If there is kyphosis, you need to straighten it. You need to go anterior. Very important, crucial decision. If in a kyphotic spine you go from the back and destroy the posterior support, it's going to fall and he's going to collapse. So whenever there is kyphosis, you must think of anterior surgery. 1. Second principle, if you want to span 3 levels or more, think posterior, because it is very difficult to get a 4-level stabilization anteriorly. It is very difficult, not easy. To get a shape of bone in the shape of the lordotic cervical spine is very difficult. And to get a cage which is curved, very difficult. You will end up putting a straight cage. You will end up making the spine absolutely straight, and not having that the extension part, and your construct is going to fail. So, kyphosis anterior, more than 3 levels posterior, age more than 70 years posterior, much safer. Anteriorly, you land up into all kinds of problems because of the trachea and the esophagus. So these three principles you must remember: kyphosis, number of levels, age. However, keeping all these in mind, it has to be individualized to the patient. Has to be. Go posterior, safest. Doesn't matter. Or you should be skilled enough to address 3-level anterior surgery. If you're not, don't touch it. Don't touch it. Doing a 3-level corpectomy, getting a cage and a plate, and giving a lordotic shape to the cervical spine, you need to have your white hair and 50 years of age. So don't attempt it. That's why I said it's an individual decision based upon the patient. Generally, these three things apply: kyphosis, anterior, more than 3 levels, posterior, age more than 75, posterior. No. You might do a laminoplasty. Or if there is ankylosing spondylitis, everything is fused anteriorly, you might get away with a laminectomy. So it depends upon an individual patient. There can be no generalization. The general rules are these three. Remember that. Kyphosis, anterior, more than 3 levels, posterior, age, posterior. Bring me the case, I'll give you the answer. Sit down. Well, if there is a fracture, then only that body needs to be addressed. You don't need to address higher. If the body above that is normal, why should you take it out? If the tumor is involving only one vertebra, you need to deal with only one vertebra. Why should you destroy the body above and below? You should never destroy normal bone. As much as possible, preserve all normal bone. All. Anywhere. Never destroy normal bone. Yeah.
Size of the lateral mass and pedicle different in C1 and C2, because they say that it's C1 lateral mass and C2 pedicle. When C1, C2 screws are used, it's called C1 lateral mass and C2 pedicle. They're both.
Of course, the shape of C1 and C2 are entirely different. The C1 is like a ring. Everything is small. The lateral masses are small. There is no body. The pedicle is thin and small. So to put a pedicle screw in C1 is impossible. It's very difficult. Don't do that. Some people do it, but you should not attempt it. While C2, there is still a lot of bone, so you can theoretically put a screw in C2. You can put a screw in the pars, which is simpler because it is just between the facets above and below. Or you can even put a pedicle screw in C2 because there is enough bone there. But your angle needs to be much more medial, like I showed. It's almost 40 degrees medial, the pedicle, cervical spine, and it is 10 degrees upwards. So to put that screw in that perfect angle is difficult. You should have a lot of experience, or you should have a good imaging facility in the OT. Yeah. You see, it depends upon what pathology you're dealing with. It depends upon what pathology you're dealing with. So, and which region in the cervical spine you're dealing with. So, if you have, suppose there is a C4 injury, so if you go 3 levels above and 3 levels below, it is dangerous. So that means you'll end up fusing from C1 to C7, and because you shouldn't stop at a junction, you will go to C to T2. So that's crazy. So it depends upon what you are saying is true maybe for thoracic spine because there are 12 vertebrae. So that depends. Yes, it is true probably for thoracic vertebra. Yeah. One second. No, if it is kyphotic anterior, I think you should need to repeat it. Everybody say this aloud. Kyphosis anterior. Say it. Say it again. Never make that mistake. Kyphosis anterior. You need to straighten it. You need to do some cage or something to make it straight. So you need 360 degree. That means you need to go front and back. Well, theory is fine, sensory symptoms, etc. is fine, but the biomechanical, you need to take care of all these things. What is the force? What is the bone? What is the quality? What is the age? Whether there is kyphosis and how many levels you need to span. If it is a multi-level thing, you can't do it from the front, 4 levels. So you need to go from the back. Yeah.
If there is L2 fracture, L2 vertebra and we can go for step L1 and L3, or we have to go T12 also.
No, it's difficult to generalize like this. You have to have the patient. You have to have individual patient, and then you individualize the treatment. You can't generalize like this. Otherwise, you follow the injury classification score. There is a beautiful scoring system which takes care of neurology, which takes care of anatomy, and it takes care of the posterior ligamentous complex. So based upon these three, you give a score, and if the score is more than a particular thing, you need to stabilize. Follow the principles. Follow those classifications. Yeah. Well, it depends. It depends. Many people just do in situ fixation. They don't use any hardware, especially the old timers. They put bone graft, intertransfers bone, or between the two lamina they put bone, denude the lamina, freshen the bone, and put graft. Or if the listhesis is too much, they put those screws which go from one body to the other, just that, without reduction. So in situ stabilization, that is the concept. So in situ stabilization can be done without instrumentation or with instrumentation. But you need to do some kind of fusion, because if it is listhesis and you just do a laminectomy, you are going to worsen the whole thing. So reduction is not always needed every time, but I think fusion, you should do fusion. At least you should do fusion, if not reduction. Anybody else? Clear your doubts now, because very important, very important. Basic fundamentals you must know. Okay, I think. I don't think we have long-term results. You see, to make an opinion, you need data. And Dr. Goel's facetal fusion, there is no data. So what is there to say? Nothing. It's a new thing. It's like a new car being launched by a company. Doesn't mean anything. Unless you watch it for the next few years, how it is going to behave on road, nobody can say anything about the car. Similarly, for any new operation. Only long-term data will show us exactly what is happening to the patient. Anything else? Okay. इसको निकालो, इसको कैसे एग्जिट करना है? Some people have to leave. Somebody said half an hour leave. आपका कौन कौन से स्टेशन है?
Which is the roof of third ventricle in its anterior part. So you need really a fine instrument to grab it and deliver it to this side. Even this is big. I'm looking for correct instrument which will grab it and deliver it. And you should not let its content spill into ventricle, or it can lead to aseptic ventriculitis. So immediately, if there's any spillage of content, it should immediately go to suction. You just gently deliver. You don't pull it, otherwise you can avulge it from its attachment. And now you can see that the third ventricle can be seen. And now I am trying to dissect this part. So you can see it's adherent to choroid plexus. You have to separate it from choroid plexus. Once you coagulate choroid plexus, the space available to you also increases. At this moment, I realized that half of the choroid plexus, you are getting to see only half of it. The half is lying behind, like here. So this part is surrounded by choroidal vessels. You can see this part. After coagulating and cutting these vessels, you have to go to this posterior part. Then only will you be able to achieve the full excision of it. This is thalamus striate vein. You can see this one. And this is one septal vein which is running from here to here. So all these vessels, they have to be taken and divided, releasing the posterior part of colloids. Then only will you be able to circumferentially dissect it.
You like using stylus only or do you like
I think Vesalius is I think much better. So once you reach here, now you can deliver from its attachment.
whatever said and done? There are so many people who say to go do endoscopically, you take it out, delivery is it. But look at the kind of expertise that a person has in vascular process and research that you can never get in.
This dissection cannot be done with endoscope.
Never in the and to me, I mean, yes, you can do it endoscopy. But however good you are,
See, these fine choroidal vessels, if they bleed, patient will have IVS and other problems. So they have to be coagulated and dissected with
Whatever
only.
corridor that you use, you go subfrontal through endoscope, whatever, wherever you insert the endoscope, the basic limitation will always remain, which is the dexterity. Okay.
So now you can see it's fully mobilized now, and we are at its last part of our attachment.
And colloid cysts are known to regrow. They'll come back.
Yes, yes.
regrow after 20 years.
Yes.
But you have only 5 years follow-up, so you say that
Ah. The operation has been successful. Endoscopes have been there for last 10 years only. Who knows? So we have seen people coming back with colloid cysts here, operated elsewhere, operated by us. Okay. And in neurosurgery, just take it out of your mind. Who cares how big the incision is? This incision can be even smaller. You can do it with a smaller incision. You can do it with a bigger incision. What patient is bothered about is only neurology. You injure a person using something which you are not good at. I mean, at the end of the day, the whole case is lost.
microsurgery is
Yes. So there are many people who compare endoscopic surgery with laparoscopic surgery. No, both are not comparable. Laparoscopic surgery is being done in a huge abdomen. You are operating in a very confined kind of an environment. And when you move an endoscope like this, you're moving it through the brain only. And look at his scissors, they are going directly inside till the point where the colloid cyst is. He is cutting it. No injury, nothing is happening. What is holding it is just the retractor. That too is interhemispheric. This is
transcortical.
This is called
Patient had
transcortical.
hydrocephalus.
So even with transcortical, once you have placed the retractor, once he has placed the retractor, he is not moving it again and again. But with endoscope, with every time you go in, you will move it.
So even EVD was also not placed, and this was his post-operative CT scan. She is doing well.
Okay. Any questions for Dr. Hitesh? You can ask anything you want. अरे कुछ तो पूछो. EVD. Let me reframe. You want to say that if you don't put an EVD, there is chance of CSF leak. This is what.
No. See that if CSF is leaking from wound, then patient has hydrocephalus. If you have opened all pathways and your ventricles are clean, there is no blood, then it won't leak. Even after ETV, suppose even after if after ETV patient has CSF leak, that means yes, then it's not working. Same with ventricular surgery also. EVD at best can give a temporary relief for 3-4 days, but it comes with risk of infection. So if you are very sure that you have open pathways and the ventricles are clean, then you may completely avoid putting it. If CSF is leaking from a scalp wound, that doesn't mean that your closure was poor. That means that there is problem with CSF pathway.
you can switch to my laptop. This is switch button. ये अभी क्या वहाँ से आ रहा था ठीक जा रहा था नहीं ये आज मैंने ठीक से करा हेलो पहले रेडियोग्राफी चल रही थी
Hello, Dr. Francisco.
इसको निकाल
Can you hear me?
निकालना इसको
while we are establishing the connection you can continue to ask whenever foreign faculty is here Dr. Hitesh will ask 10 number of questions. And if you are not asking questions from Dr. Hitesh, I think you have learned nothing from it. So Dr. Hitesh will go to OT and not leave the foreign faculty at the dinner table or at the lunch table.
I don't want same thing to be done to me, don't worry.
So the same thing should be done to him. Dr. Francisco, can you hear me? I can't hear you. The audio. Can you connect the audio? He says that he can hear. Hello? Hello? Dr. Frank? Dr. Prada? Dr. Prada, we are trying to settle things at our end. Just wait for a bit. We are trying to troubleshoot. कंप्यूटर को ऑडियो यूज करो और इसको ऐसे करके Hello, Dr. Prada. Hello. Dr. Prada, can you speak? You cannot hear me. Hello. तुम एक बार अपने फोन से लॉग इन करके बोलो मैं आवाज में क्या हो रहा प्रॉब्लम ये आवाज में
Hello. Now can you speak again?
Yes,
Yeah.
do you hear me?
Yeah, now we can hear you.
Oh, awesome. How are you?
Now we are fine. And thank you for accepting the talk at the very last moment.
No, don't worry. It's a pleasure. Thank you for the invitation.
So there are many delegates here. I will try switching on the camera on the other side so that you can hear and see them. And they are physically present. Most of them we are physically present here. So can you switch on the other camera?
Okay.
Susan, can you switch on the other camera so that Dr. Prada can see? Just rotate the camera to
I trust you anyway.
Yeah, so no, because then it will become interactive in the way they can ask you questions and they can also.
That would be awesome.
So they can ask questions from you. So let me set it up. We are doing it for the first time, this hybrid thing. So that's why I told you. I mean, there can be few problems, teaching problems can be. I hope you can hear with us. For a moment. So this is after the COVID pandemic. This is the first time that we are holding a physical workshop. How are things in Italy right now?
Good morning or afternoon, everybody.
Yeah, so now you can see, I mean, this is where we are sitting. There are three or four halls here. So there are people in every hall and they are listening to you. So just a very brief introduction. I met Dr. Prada in Mumbai during a workshop. And he's a very fine researcher, has done a lot of work in the field of ultrasound and technology, developing it, learning how to use it. And I contacted him just 1 or 2 days before. I thought we have an ultrasound station here where you are learning. And maybe Dr. Prada can teach us some final points about the use of technology and how things are advancing in this field. Compared to intraoperative MRI, use of ultrasound is very cheap. Nobody can afford intraoperative, I mean, very few people can afford intraoperative MRI. But ultrasound, yes, everybody can have in their own setup and they can use it. So I'll request Dr. Prada to start his talk and maybe you can start sharing the screen. I will switch off my mic so that there is no disturbance and you can speak directly to the audience.
Yes. You should allow me to share the screen.
Yeah. Okay. So now you can share the screen. So can you all share what is correct?
Do you see the screen? Do you see my screen?
Yeah.
Switch to full mode.
We can see your screen.
Okay. So that's great. So first of all, good morning or good afternoon, everybody, and thank you, Dr. Tanner, again for the kind invitation. And I've been asked to talk about the use of multiparametric ultrasound in neurosurgery. And I will focus my talk on the use of contrast enhanced ultrasound, which is one of the modalities that we will see throughout this presentation. These are my disclosures. So ultrasound, as Dr. Tandon already mentioned, is a very useful tool for surgical guidance. And it's cheap, true, compared to other imaging modalities for sure. But it's not only, it doesn't only allow to save money. It also allows to save and I would like to stress the importance of considering ultrasound as a multi-parametric imaging tool, because we usually don't have any, as neurosurgeons, we don't have any exposure to the use of the direct use of ultrasound. We use usually transcranial Doppler for vasospasm, but there is no, it's not a diagnostic tool, so we are not familiar with this technology, such as we are, because we are with the CT or really, and we often refer to ultrasound talking only about B mode, but there are many other imaging modalities, as you can see in the panel. And it's not only a tool for surgical guidance, it's also a tool for research to understand the pathophysiology, because we can obtain many information from intraoperative ultrasound, because we can have information about the blood flow, we can have information about the tissue perfusion, about tumor perfusion, we can have information with elastography about the mechanical properties of the tissues. And since every time we perform a craniotomy or a laminectomy, we expose the nervous system, we get rid of the problem posed by the presence of the skull, and we have a window, a real window, to study the brain and also to have surgical guidance. And as I said, this can be basically applied to almost all aspects of neurosurgery, from tumor surgery, which is my main area of research, to vascular surgery, trauma, epilepsy. And I want to stress the importance of not referring to B mode only when we talk about ultrasound, with an example with another imaging modality. Here you can see a T1 weighted MR showing a parietal glioma or intrinsic lesions, let's say. I think that no one will perform surgery relying only on this image. For gadolinium-enhanced MRI, T2, flare, and perfusion, and you name it. And truly, the same can be done intraoperatively in 5-10 minutes with ultrasound. Here you can see frontal glioma as seen with on B mode, which provides us with morphological and anatomical information. Then we can get information about the vessels in the tumor, fusion of the speed of the perfusion, speed of the flow, or the mechanical properties. So it will take too much to talk about all these aspects. So now the topic of this presentation is about contrast enhanced ultrasound, which I think is probably the most fascinating, also because it has a therapeutic application with as we can see afterwards. So what are the ultrasound contrast agents? Ultrasound contrast agents were developed in the 80s to enhance the Doppler signal, and basically they are bubbles the size of a red blood cell containing gas. So they are really hyperechoic. And as you can see in the video, when the microbubble are hit by the ultrasound, they start to vibrate and they generate a signal which is specific to the microbubble. So the machine can reconstruct the image and show us where the contrast is, which is, as I haven't said it yet, it's endovascular. It's an endovascular contrast agent. It's not like gadolinium, it's endovascular. And it is able to show the micro and the micro circulation at the same time, and also high flow and low flow vessels, offering many advantages of the color Doppler, so we don't have artifacts and we don't have to change any parameter. The degree of enhancement, of course, is a consequence of the density of the vasculature. It has been in use since the 80s, and it is the contrast enhanced ultrasound modality is a modality that is very well established for other organs. There are guidelines since 2012 and 11 regarding all organs throughout the body. And actually, it is, for example, in the liver or the thyroid, it's the gold standard for the diagnosis. In neurosurgery, the first attempts were performed in the early 2000s. It's just a safety and feasibility study, but much more has been developed since then. What can we do with contrast enhanced ultrasound during surgical procedures? So this is a coronal section in a coronal view, ultrasound coronal view in a frontal metastasis. We can the contrast can highlight the tumor because there is a striking difference between the parenchyma and tumors. But we also can evaluate the surrounding structures. You can see the arteries of the anterior complex. So when we perform tumor surgery, we can check the afferent and efferent vessels, so we can plan the surgical strategy. And simply tilting the probe, we can visualize different structure without having the need to change any parameter as we have to do with the Doppler, because the image that we get from the microbubble is independent from the angle of installation. We can highlight tumors, but we can also clearly, as you can see in this picture, where we are looking polygon of Willis through a temporal approach. And really, we have a resolution that goes down to the capillary level. We can characterize, visualize, and characterize virtually all kinds of tumors according to their vasculature. Because, as I said, the normal parenchyma is not really hyperechoic with contrast enhanced ultrasound. Here you can see different type of glioma, and you can evaluate how the morphology is different. So we can also characterize brain tumors, for example. As you can see, low-grade tumors, they tend to have a low enhancement, whereas GBM, they have a very high enhancement with a homogeneous pattern. Then we can visualize all sorts of tumors such as pituitary adenoma, hemangioblastoma, or epitheliomas. And of course, also metastasis here, or meningioma. Interestingly, there are some peculiar cases, such as radiation necrosis, where we have an enhancement on MR, but since the gadolinium here extravasate, we don't have a real perfusion in that area. We see it as a flow void with contrast enhanced ultrasound, and the same can be said for abscess, for example. Contrast enhanced ultrasound can be repeated throughout the procedure, the surgical procedure, and can be used also to assess section control in intraaxial tumor. Here you can see temporal glioma. This is a surgical cavity halfway through the resection, and we have this hyperechoic area on the mode. If we re-inject the microbubble, we appreciated the still enhancement of this parenchyma. And we did a study in 20 cases. This specimen were analyzed separately, and we showed that there is that this was a viable tumor. There are also indirect signs that we can appreciate, and this is the interesting part on ultrasound, because we can really get pathophysiological data throughout surgery. So you can see in this case was a ganglioglioma. We had this hypertrophic medullary vein draining towards the ventricle because the tumor acts as a shunt. Once the tumor is removed, here you see the surgical cavity, we have the disappearance of this hypertrophic vein. If we couple contrast enhanced ultrasound with fusion imaging, with navigation tools, For example, in skull-based tumors, we can, where locating the surrounding vessel is crucial, we can navigate the contrast imaging and clearly localize in the surgical field critical vascular structures. Of course, in vascular surgery, it's a very helpful tool too. This is an example in a case of a middle cerebral artery aneurysm. And also in spinal surgery, we can clearly visualize the point of fistula and the engorged veins on the spinal cord. What is very helpful in vascular surgery is that we can, of course, have a morphological evaluation of the vessels of the lesion of the aneurysm. But after clipping, we can also use microbubble imaging to assess the patency of the distal vessels, first and foremost. But also, because we have a tomographic section of the brain, we can assess the perfusion of the parenchyma in depth. So it's a very helpful tool when used in conjunction with optical imaging such as ICG to verify the perfusion after the procedure. Because of course ICG shows only the surface, whereas with ultrasound we can assess the depth with the tomographic section. This is an application for epilepsy surgery. For example, focal cortical dysplasia, they have a higher content in vessel density compared to the brain, to the normal brain. So we can evaluate and visualize this lesion as well. And, as for brain tumors, contrast ultrasound clearly enhance spinal cord tumors. And for example, it is able to show the nodule, especially cases where we have extravasation due to venous hypertension.
Hello, Dr. Prada, we cannot hear you now.
Are you still there?
Yeah, we are still there. We can now hear you, but we cannot see the screen.
Something occurred. Sharing the screen again.
Yeah, you can share the screen again.
It is possible to. Do you see my?
Yeah, now we can see.
Okay. So there are differences in the permanent deficit or temporary deficit. And also, of course, it can be used for surgical because microbubbles are really safe. They are used basically in every radiology department all around the world. It is possible to perform more sophisticated analysis. We can perform quantitative analysis, and you can see how the microbubble distribute in different areas of the brain. Of course, tumors and arteries have the higher amount of microbubble, whereas white matter areas have a lesser amount of microbubble. And this is in the upper part of the slide. You can see how the timing and the morphology changes in time. This is where the microbubble arrives. Then we have the peak. We have different phases that are helpful in differentiating different brain tumors. As I said, glioblastoma, for example, they have a high degree of enhancement compared to low-grade glioma, and also they have a different timing. It can be used in order, as I said, to perfusion of the parenchyma and tumors. Using irrigation, we can compare it with, for example, as in this case, with the perfusion, so we can perform direct comparison in different imaging modalities. and it is also possible to perform 3D microbubble distribution. So I will quickly give an overview. What do we need to learn or teach how to use contrast enhanced ultrasound? So it is a very well regulated imaging modality when we talk about general radiology, but I think we shouldn't be differently. So there are really guidelines on how to perform contrast enhanced ultrasound, and it is important to use understand the terminology, understand all the physical properties and imaging modality, and learn about different ultrasound contrast agents. It is important to have a system, a high-end ultrasound, which is, of course, as Dr. you mentioned earlier, it's much cheaper than other imaging modalities. That is equipped with the contrast enhanced ultrasound option. Might seem complicated, but what you need to do is to have a preset and just a button. The setting in the is the usual setting. You just need to have your machine sitting closer to you. I usually prefer to operate the machine myself. One of the criticisms towards ultrasound is that it is operator dependent, but the surgery itself is operator dependent. So I think it's not a big deal to learn how to use an imaging tool, which is very useful. These are a couple of examples of the parameters and how the image change when we change parameters. So you can see where, as with the mode, if you change the frequency, you have a better visualization in the shallow areas with high frequency, but you have a less penetration. Or this is what happens when we change the focus, because this also have issues on for therapeutic purposes. It is important if some one of you will start using contrast enhanced ultrasound to collect data in a homogeneous fashion. These are the guidelines from the European Federation for Ultrasound in Biology, the latest, in which they included neurosurgery, and there was this panel of experts who deemed the use of contrast enhanced ultrasound in neurosurgery very useful. But of course, the level of evidence is really low, especially our numbers are very low compared to general radiologists. There are also, looking into the future, options for post-operative the use of a post-operative use for ultrasound. So we are developing an ultrasound transparent prosthesis that should replace the patient's bone flap. And this will pave the way to the possibility to perform in a post-operative setting contrast enhanced ultrasound guided microbubble mediated therapies, and also follow-up. Because as you can see, when the microbubble interact with the ultrasound, of course not a set of experiments that were conducted in my lab here in Milan. So in conclusion, contrast enhanced ultrasound provides real-time and high-resolution depiction of different structure, both in the brain and the spine and in the peripheral nerves as well. And it's a useful tool for surgical guidance. It is an interaction between microbubble and ultrasound has potential for follow-up and therapy, because in the end,
we cannot hear you again, Dr. Prakash. Can you hear me? We again cannot hear you.
Okay.
Now I can hear you.
Oh, okay, awesome.
I must thank you for a very nice and enlightening talk, because we in India have not used the contrast enhanced ultrasound. If any of the delegates have seen, then I'm not sure, but at least we have not used it in AIIMS here. So if anybody has any questions, they can direct it to me and I will ask Dr. Prada. Anybody who has any questions? So I have few questions for you, Dr. Prada. So do you require any special kind of a license for using contrast enhanced ultrasound?
No. As I said, you need to have a machine equipped with. I mean, it depends on also on the regulatory bodies in your country. It depends
No,
if you have.
Is there a special software to analyze the image of the contrast? Or is it just the usual B mode or M mode, whatever you use?
No. You need a machine with a dedicated software, because you need an algorithm to disable. It's like a digital DSA. It's like digital subtraction and geography. So you need
do you require to purchase that software extra? Do you have to spend in buying the software?
No. If you get a machine that has the algorithm, you can.
How much does a contrast specifically cost a person? I mean, whenever you are using it, how much it adds to the surgery?
Sorry, I didn't get the question.
What is the cost of contrast?
The cost of the contrast?
Yeah.
So the cost of the contrast here in Italy is around €100 per vial, and you usually use one vial per surgery.
Okay. And is there any contraindication?
You need to use the contraindications.
We cannot hear you again. Some problem with the network, I guess.
Okay. So as I said, the issues, the contraindications are severe heart failure or COPD.
Okay. So you have some very wonderful papers in World Neurosurgery and Neurosurgery Focus. Have you ever looked at the extent of resection that is affected by use of contrast enhanced ultrasound versus the non-contrast, usual one? Cannot hear you again. I think there's a problem with the link.
Yes, I think so.
So have you studied the role that contrast and ultrasound plays in improving the extent of resection or improving the progression-free survival in a patient?
Well, not yet. We have a study ongoing. I think the problem here with, for example, with GBM is not only the use of contrast, but or the extent of resection, it's the location of the tumor. So there are bias, I think, in general. We published a study using B mode, navigated B mode, and actually we showed that the extent of resection is enhanced when you navigation, ultrasound in combination with navigation, compared to ultrasound only, because you have more confidence actually. There is a study from a group in Rome where they compared and they didn't compare. They studied the use of the combined use of LA and contrast enhanced ultrasound, and they showed that there is an improvement in the extent of resection.
Okay, thank you, Dr. Prada, and I thank you on behalf of all the audience for taking this wonderful lecture and taking time out of the busy schedule. And in the afternoon today, we have one more lecture from Dr. Sarvade, and he will be taking an oration. I will send you a link, and if you want to view his oration,
then you can join directly to the YouTube link. So he is also from Milan. I hope you know him. So I would thank you, and we will close this session and we'll move on. Thank you, Dr. Sara. I'll get in touch with you and I'll send you few pictures of what I have been playing here. Okay, thank you.
Okay, thank you very much.
Okay,
Bye bye.
bye bye. So now what we will do is, those of you participating as teams, and if one person is single, then we will allow the fifth person who is there in the list, and he can partner you. Okay. So best of luck, and Dr. Nivedita will tell you rest of the rules. She can be here. We will display the questions here, and for every question you will get 30 seconds to answer. Okay. So have you distributed the sheets to them? KP is here. KP, you can, Dr. Kokula will brief you about the rest of the rules in case there are any, and if I've missed out on anything. If anyone has any objections, you can raise it with Dr. Kokula right now. And those of you who are not participating in the quiz, I will request you to go and have lunch so that once this batch is free, they can have lunch. So there will be no crowding there. Okay. So all of you can sit in distance. Don't crowd with each other. Don't try to speak. In the meanwhile, all of you have completed the workstations here, or do you want more? We had created the batches only to realize that none of you is following the batch rules. So you are going wherever जहाँ भी ज्ञान बट रहा है वहाँ चले जा रहे सारे के सारे. So what is it that you want? You want us to keep these sessions open in the afternoon? You want them to be open, okay. So those of you who have completed all these sessions, you can come here. Like Hitesh showed you his case, now Dr. Sachin is also here and he can show some videos of his. And if you want, we can ask Dr. Manmohan also to come here and show some videos, wonderful videos and talk. Maybe you will learn more. And all of you keep your mask above your nose.
I hope everyone is here. Nobody is missing. All the delegates know. Can anybody put that on the delegate group that if somebody is missing, they should just walk in here right now. They might be loitering around in South X shopping.
They have left for lunch.
So how many of the outside delegates are residents? Can you just raise your hand? And how many are practicing consultants? Very few. So we are basically in this time, we felt that elderly people might not just walk in. So we thought that we should focus on residents and we should talk of basics and we should revise our knowledge. That's what our focus has been. But rest of the times when we do microneurosurgery, we call few stalwarts from the world and they come here. They talk of something which we also probably might not be doing here at AIIMS. So it's a different ball game altogether. But this time I think even revising the knowledge is a very good idea. Because as we also grow in years, our technique changes. And there might be somebody in my department who might be operating a similar kind of a tumor in a different manner altogether. So it is good fun to see everybody. And there is something to learn from everyone. I mean, all of you can also add on whatever your consultants are doing, whatever you are doing. You can also tell us that what is it that you do, how differently you approach a patient in your setup. Okay. So all of you have come from very far-flung areas, from right from the Kerala, Maharashtra, everywhere. So what about COVID? Yeah. All good. And what about the hospital policies? Are you following COVID policies? How many times you are testing? How many times you are testing? It's from here only. What about you? No, gentleman behind you. Can you hand over the mic to him?
Hello. Good evening, sir. So for elective surgery, we get COVID done within 72 hours. And for emergency surgery, we do it without COVID, but we send a sample and we do fumigation after every case.
After everything. And what about PPE and all that? Do you wear everything?
We're not using it right now.
No, not using. Normal, usual mask that you're using.
Yes.
And where are you from?
RML.
RML. Okay. Anybody from outside Delhi? Maharashtra, what is it that you are doing in Maharashtra? Anyone from Maharashtra? Please tell.
Sir, for emergency surgery, sir, we are using PP.
Okay.
Because
For emergency surgery?
For emergency surgery.
All
emergency surgery.
You You're using PPE.
Yes. There's a separate
So do you use the shield also?
Everything.
Everything. And which place in Maharashtra you are from?
I'm from ASMC.
ASMC. Okay. But how do you operate with so much of PPE?
It's difficult, sir, but
It's difficult. I think it's kind of impossible. I cannot use microscope with PPE at all.
So emergency surgeries, not.
Okay. That is interesting. Anybody else who is using PPE? I think our resident Hitesh, all of you left using PPE long time back. They are not using it. I think Hitesh was not interested in wearing PPE in COVID ward also yesterday. He was posted in COVID ward. His only complaint is that I couldn't sleep because I was wearing PPE. Anyway, so are we set, ready to go? So I think you can show them, start showing them the questions. So every question has a multiple choice question. There are positive marks and there are negative marks like the AIIMS pattern only. So 3 positive, 1 negative, it's like that. So choose your answers correctly and carefully. Okay. And you will be given 30 seconds for each slide. So anyone who cannot view it, please come forward. I mean, rather than sitting at the back, if you can't read it from the back, you will have to hurry up and it will be a problem. It's better to come forward then. So from which laptop you will project? ये वाले लैपटॉप को कनेक्ट कर दो. एक मिनट अभी उसे ऑन नहीं करना. एक मिनट अभी ऑन मत करना आप लैपटॉप को. डोंट प्रोजेक्ट. रुक दो. फर्स्ट let's start. ठीक है प्रोजेक्ट So this slide will change after 20 seconds. The next slide will come and the transition is set at 30 seconds.
questions and then answer Dr. Dwarka. Yes.
It is sir, who was formed to be right,
कौन कौन से स्टेशन कर रहे हैं और तुम्हारा वो बचा है इलेक्ट्रॉनिक का बीच में जाके कर सकते हो तुम कहाँ से तुम्हारा तुम पार्टनर के घर से होते हो both of you are 6-year candidates अवतार से into skills से और तुम कहाँ से तुमने skills से बड़ा नहीं है hardest job. So all of you are resident. We are trying to search for some videos, whichever video we find will show you, and we will discuss with you. ये कहीं से मिला ये रुको तो हितेश को ही पता है कैसे Deveta, do you know what is the sequence of this video? What is the sequence of those videos? तो कौन कौन से सेगमेंट दिखाने थे Can you call him because he will be known? Can you number yes, okay. So can you just start from here and do you know of any patient which has some cervical problem? Show the video. There are multiple shifts, there are 37 shifts. We'll go one by one. Okay, that was me. So this is a video of a patient where anterior cervical discectomy and partial plating was done. Not done by me, but somebody else.
So what is not shown here is how do you position a patient for ACDF? Because that is the first thing that you do, position. So how do you position in NIMHANS for anterior cervical discectomy? So we'll try some new age techniques. We'll see and Google and check and show you how to position, okay? How do you position in NIMHANS? Supine with neck extension. Do you use traction there? Okay. हाँ लाइव कर दो कोई बात नहीं. So you can see here, there are multiple images that you can see here. So at every other place, I mean more or less it is constant kind of a thing. You place a person in supine position
with neck extension. But what is it that you want to know beforehand before you extend the neck of a person? Or you flex the neck of a person in anterior cervical discectomy. What is the problem if I extend too much or flex too much? If the compression is very high, a person can land up in a problem. Okay. So beforehand, before you do, when you are doing a pre-operative examination, an important test is you ask a person, can you flex your neck? Can you extend your neck? Can you show me? If a person says in this kind of a position, I am developing paresthesia, I develop tingling in hand, I develop this kind of a problem. So that's a red flag. So don't try that kind of a position where the extension is either too much or even the flexion. If you are doing any cranial surgery, like you are operating a posterior fossa case and you have to flex a person's neck, or you are doing some case for CVJ where the compression is too much and you try to flex so that you open up the neck and then you land up in a problem. So pre-operative testing therefore is very important. So you should know. So you can place a person like this or maybe like this. See what they have done here is they have strapped the hands. So usually if the disc is at what level, you will not be able to see in II. Can anybody tell? So disc if it is at C6, C7 or in a very short neck at even C5, it is difficult to visualize. So in that kind of a condition, you need to strap the arms and stretch them. How much will you stretch? And what is the problem if you stretch? Sir, आप भी कुछ ऐड करते जाइएगा. Sir, so what is the problem if you stretch too much? Yes. So a person dislocation is very unlikely because you are trying to push. So dislocation usually happens at the shoulder, but you are not pulling the hands. You are pushing the shoulders down. Somebody stands here at the head end, and then a person tries to push the shoulder down. So dislocation of shoulder usually will not happen with this. But brachial plexus injuries, if you stretch too hard, they can happen. But if suppose you're still not able to see, you have done all this maneuver, but still you can't see C6, what else you can try? So you can put a roll here, like somebody has put a roll here below the neck, but that still will not help the cause because the II will be placed here, II will be placed here. Still you will not be able to see because that will not change the angle of the rays that will pass. The rays will pass only in the straight direction. So what else you can do to visualize? Yes, what is symmetry? So you can try that. Okay. Another thing before even doing that, raising hand again, that can lead to axillary nerve injury or even dislocations of shoulder. That's not very advisable. But what you can do is you can tilt the position of the II. Suppose the II is placed like this. Beam is coming from here and beam is going there. So you can tilt the II. You can bring the beam which is here and you can collect it here. Yeah. So slightly oblique you can help you realize where you are. Okay. If everything fails, you're still not able to see, then what will you do? Still it's not clear. Then what will you do? You will have to operate a patient. Still it is not clear. You can see C5, you cannot see C7, T1. What will you do? You will take an AP view. Okay. AP view can help you because you can see where the first rib is starting. The first rib will start at T1. So you can take the T1 as the starting point. So in skims, what kind of incision do you place? Horizontal incision. Anyone who gives vertical incision in their setup? Practically no one. Because most of the people now realize that you can do with horizontal incision. When we were training, some people used to give horizontal incision or vertical incision. But I think if the corpectomy is more than 2 levels, then maybe you can give in a person who is short neck. But otherwise, you can get away with the horizontal incision. And where will you give horizontal incision, preferably? Yes. So from the midline to the sternocleidomastoid. See, somebody has already shown you here. That's the power of Google. You don't require any PowerPoint presentation. Everything is there. So somebody has already shown you. This is the marking for sternocleidomastoid. And from here, they have marked an incision here. So it is a personal preference how large an incision you want, how comfortable you are. But in the beginning, I would suggest you can give a larger incision because they all heal well. They don't look like a bad cosmetic scar until unless you have stitched them very badly. So you can give slightly larger incisions in the very beginning and then tailor it down as your experience increases. Okay, because the bottom line is that without stretching too much, you should be able to reach these discs and you should be able to take it out. Okay, so you give an incision like this. Okay, and then the first step is, let's see what the video shows. Even I don't know what is there in the video. We will maybe, if we had an apple, we could have run it faster. So they have marked. So the first thing that you do is before marking, you take an X-ray with an II and check whether your position is right bang on top of it or not. You can alter the incision little bit depending upon the skin crease which is there. You can go one level up, one level down depending where the skin crease is, and still you will be able to reach the disc without a problem. Okay. So see, he is going to incise here. So this is unedited video. It has a fun of its own. It's not like an edited video. It's like a whole surgery is going right in front of your eyes. So it will be slow. And if you have any questions, you can keep on asking. So there are two ways of doing surgery. One is very quick. Just cut, go right inside, take out whatever blood bleeding is happening, you allow it to happen. But in my experience, if you're doing ACDF, you need to be very meticulous from the very beginning. If you are able to control all bleeders, which there shouldn't be many, because if you maintain the plane, there is no bleeding practically after the skin. So if you maintain good planes, then there is no problem. But here, if you see bleeding, something which is pouring in, it can be problematic at a later stage when you are inside. So it is better to be careful here, use bipolar and even monopolar if it is required below the platysma to clean and to coagulate and then go inside. So what is this that is seen now? He is cut. Can you see here? He is lifting the forceps and he is cutting with the monopolar. So what is he going to cut? Yes. So many people, what they do is they will lift this whole thing up and they will go below the subcutaneous fat. So that is not required. You have to go subplatysmal. That is what the book says. So cut the platysma first. Okay. It's a very thin layer of muscle which is here and can be very easily visualized. You cut it, you lift it, and below it you create a pouch, above and below, in this direction and in this direction. Okay. So this all is being done by our residents, not by anyone else, and therefore there are few steps which may not be proper here, and that is why we have kept this video. So all this also can be done with a sharp dissection. He is doing with monopolar, but I prefer using a sharp dissection more often than not. And if you are using monopolar, use the cutting part of it. The yellow button you have to press to cut it. You are not coagulating, you just have to cut it. And avoid using monopolar on the skin, that leads to a bad scar. Okay, so don't burn the skin. So now once you have done, what can be done is, I hope he has that part. So what I do is, I ask my assistant to lift this part up, I ask my assistant to lift this part up, and I put my Metzenbaum scissor here in this plane. Okay. And I put again Metzenbaum scissor here in this plane. And I just open it. Once you open it, what will happen? Plane obviously will be created. At times, here the veins are going from this direction to this direction. So be careful of that. Sometimes they can be very big and can bleed profusely. If the vein is very big and you think while retracting you are likely to rupture it, then it will retract and then it will bleed. So there is no harm in coagulating or even tying a vein if it is very big, and to stop the bleeding then and there. But more often than not, it is nothing is there, nothing is required. It is occasionally that this happens. Can you, Priya, can you call Hitesh here? You see, now he is doing what I was telling you. You just put in here and do it. So if you are careful, even these bleedings, they don't happen in the expert hands. They don't happen. In minor bleeds can be controlled. So we'll go to the next part of the video. Let's see what is in segment 2. So now the next step is, once we have created the pouch, what is the next step? Searching for carotids. He says searching for carotids. What about you, Sarthak? No idea. Okay. Anyone else? So now you basically want to enter into a plane which is medial to sternocleidomastoid. Okay, and lateral to the strap muscles. And then you want to retract it so that you can go down and reach up to the prevertebral region. Okay, so that is the next step. See, now he's using, I prefer using sharp dissection only. He's using sharp dissection, but obviously there is some bleeding. You can see some vessels. So what is the best way to identify this plane? At times people are fatty. You will not be able to understand where to go. What's the best way to identify that plane? Because what can happen is you can go lateral to sternocleidomastoid, or you can go medial to the strap muscles towards the midline if you're not careful. And then you will enter into the wrong areas. How will you identify it's the correct plane that you are in? Exactly. So the plane will be absolutely avascular. If you are in the correct plane, you will not encounter any vessels. Not encounter any vessels. If you are encountering leash of vessels going this direction, leash of vessels going in this direction, up or down, you are in the wrong plane. Okay. So the plane is very, very avascular and it is very clearly defined. And how do you identify that plane? Suppose a person is thick, webbed neck, there is a lot of fat, you can't discern where the sternocleidomastoid is little bit. Then what is the best way to identify the plane? What maneuver you will do to identify it? I'm not sure whether he's going to do it or not. He's still creating the pouch. So what maneuver you will do to identify the plane? So one is you can follow the medial border of sternocleidomastoid, but suppose you are not able to identify where the medial border is because it's a layer of fat at times. No. What you do is you lift up the whole thing here, like he is lifting. You lift up the whole thing. So when you will lift up, there will be a groove that will form. That will be the medial border of the sternocleidomastoid. The groove will always form between the strap muscles and the medial border of the sternocleidomastoid. Okay, if you are not sure, Then just put your medicine ball scissors and you try to open it. Once you open it, there will be no bleeding, and if you are in the correct plane, you will be able to identify it. If you think there are bleeders, it's bleeding profusely, 90% time you are in the wrong plane. You come out, clear your head, again do the same maneuver and see where that plane is. Don't get confused. Okay. So let us see the next slide. What is there? She's still there. Okay. So here he is. See, again, he is struggling to find the plane. Okay. And see, there is so much of bleeding that is happening here. Can you see here? So once you have lifted, there is a groove which is here. He's moving. Let's go here. So there is a groove which is here, which appears to me like the plane, but he has indented something here in this direction, done something in this direction. You don't have to touch anything else. Just remain in the plane. That is what the trick is. Okay. Now, there are many people who advocate you can use your fingers to dissect. So, Sarthak, in NIMHANS, have you seen discectomy being done? Second year, you haven't seen. Avtar Singh, what about you? So, how many people use fingers, and what they are using here is peanuts to dissect. So, in your center, what is it that they do? Sharp dissection, yes. So, sharp dissection is the best. You see, when you are trying to scrape off the fascia by some brute force, by using peanut or something, you are likely to rip off few vessels here and there, and it will cause lot of edema even in the post-operative period. You put in your medicine bomb scissors, you open the medicine bomb scissors, you will realize where the plane is. You ask your assistant to hold on to a retractor. Every place has got different sets of retractors. You ask a person to hold that retractor and retract little bit on the medial aspect, retract little bit on the lateral aspect. You will be clearly able to visualize the fascia that is coming down. Again, put in the medicine bomb scissors, open it, identify if there is any vessel, coagulate it, and cut it. So Hitesh is here, he knows because he is the one who has recorded the video. They'll ask him to sit here and keep on telling me. And Shashwat is also here. Maybe Shashwat can take it up from here because he was the operating surgeon as a consultant. Shashwat, this is the same video of Hitesh. So I thought I can start it when you are asking. You can also come here. ठीक है तुम भी आ जाओ क्योंकि मुझे स्टेप्स पता नहीं क्या किया तुम लोग ने. So I just telling them. हाँ. So Hitesh will keep on telling you. So according to me, the mistake that Hitesh did here, I will also show him. He is trying to retract using his fingers, search for the plane using his fingers, and then he puts in a peanut and scrubs everything. Okay. So that scrubbing in itself rips off few vessels and causes edema. In case you are going to do 2-level corpectomy, you want to do it very quickly and you don't want any edema to happen in the nearby tissues because it precludes the vision at a later part. So do sharp dissection. Okay. And if you see this much of blood at this point of time in surgery, it basically means you have messed out in plane. And you have been trying to be very quick so that before your consultant comes in or walks in, you are able to complete the surgery, some part of it. So don't try it. The faster you will try to become, the more problems you will have, and there are very less chances that you will get the full surgery. You will come and say, wait, I am coming, I will do it. Okay. So this is what usually happens. So be patient, do very slowly for few cases. You will have to spend time, and then you will be able to improve your timing slowly and slowly.
So this is what I personally do not do. Pre-operative scan. अभी तो इसके ऊपर आ गए कोई बात नहीं ठीक है because we have time maybe another 20 minutes. So here I think he can tell what is he trying to feel.
So basically, I was trying to feel the plane between the sternocleidomastoid and the strap muscle, and so I got the plane, and so I'm trying to do sharp dissection here, and basically the deep cervical fascia.
It is easy to go lateral to the carotid and go to the transverse tubercle of the patella and feel that, and you will feel like your finger.
So I'll just reverse it here again. Okay. So once you put the finger inside, okay, always try with the palm of your finger, you try feeling for the carotid. Where is the carotid? The carotid should always be on the medial aspect. It should be here. If you're feeling pulsation here, I think you're wrong. Or you are feeling it here, you are going in the wrong direction. So the pulsation should be on the palm of your finger. No, I mean you are putting your finger like this now. So you are standing on the right side of the patient. We usually operate the patient from right side, not from the left side in AIIMS. Very rare. In case there is a recurrence only, then we operate on from the left side. Otherwise, we operate from the right side only. And if you maintain the planes, there is hardly any case of recurrent laryngeal injury that I have seen. But in my personal experience, none. But yes, I've seen few. But if you maintain the plane, hardly it happens.
Usually it happens only at the lower level.
Yes. C6-7. And that too when you are using brute force like cautery. Okay, monopolar cautery, you are burning left, right and center. Then it will happen. Otherwise it will not happen. So just put in your finger inside, feel for the carotid. See to it that you are feeling it on this side. And then only move away.
Go medial to the carotid almost. Feel for carotid, most important.
Can you give mic to Dr. Shastra so that he can do it?
You can speed up the video.
ये वो नहीं है एक्चुअली इसमें VLC प्लेयर है क्या
Otherwise will take
सर इसमें से चला लेते हैं मेरे वाले में से चलाते हैं उसमें कुछ
तो मेरा लैपटॉप कनेक्ट कर
शुरुआत ये बिल्कुल सेगमेंट 3 है ये लैपटॉप को कनेक्ट कर दो आज कुछ दिखा दो तो मतलब आप आगे वाले को फ्री कर दो लेकिन 3:30 पे इससे लॉगिन करना
was the pre-op image of it. You can see that.
Yeah, this was a pre-op image. You can see that there is a fracture dislocation of involving the C5 vertebral body. So we planned for a corpectomy and fusion with autologous iliac crest graft. So
This was around 6 weeks old injury. So there was some element of, adhesions, and that's why the dissection was a little bit messy.
Preoperative traction?
No, we don't like. Yes, I think he was put on traction, but yeah.
Yeah, I forgot to tell you this, one more thing, that many of us give apply the Gardner and Tom, and we put little amount of weight, maybe 3 to 4 kg to stabilize the neck. But it is not mandatory to do it every time. Like you are operating C3-4 degenerative disc, so it is not required. But at times, cases like these, where the alignment is gone, you can give preoperative traction. But you have to use traction with a pinch of salt in the sense that in case the person is Asia A or Asia B, where the neurology is disturbed, then what will happen if a person is given traction? Person can deteriorate also. Okay. So in that kind of a case, it is better to start with the traction even probably in the pre-operative period and increase it gradually. Keep on watching the patient. See to it that he is not developing any deficit. In case the person is developing deficit, you will have to remove the traction in that kind of a situation. So just going right into the OT, putting say 7 kgs of weight, and when patient is anesthetized, will not help your cause. It may straighten the spine at the expense of loss in neurology. So you can come out saying I did very good surgery, but see patient is not walking. Patient is not walking because you have used the wrong methodology to treat. So this is better. Now Shashwat can speed up.
Yes.
That's why I said it's better to have an apple here. So carotid you can see here. Carotid is where his finger is. Carotid is here.
So I'm going medial to the carotid.
थोड़ा सा धीमा कर दो तो लोग देख पाएंगे. So once you reach here, you see longus coli on either side.
This was an old case, so usually the plane, it's a very pristine plane here. You can see the longus coli and the ALL after dividing the prevertebral fascia. So right now we are dividing the prevertebral fascia. They're monopolar. And this is the attachment of the longus coli.
One more trick here is, see, can you, Shashwat, stop here? So one more trick here is what Shashwat is doing. Is cover the tip of the monopoly.
Yeah, this is very important. Otherwise, it can accidentally touch your carotid and can burn a hole through it. And you
see how close his tip is to the part of the cautery to the carotid. Ritesh, can you point the carotid here so they can understand? Because all of them are residential. So this is where the carotid is. If the current leaks, carotid is gone. Carotid is gone, you are gone. Okay. So what I do is, again, can you stop Shashwat at one point where the suction is seen? So I also cover tip of the suction. Because once you are trying to use the cautery, your suction also touches the cautery and the current can also pass through it. So I'm very, very scared. I also cover the suction with some suction tubing which is made up of plastic. Okay, you can go ahead. See how he's retracting. He's trying to put the retractor below the muscle which he has burned. Can you see? He's trying to go below it. कुछ क्वेश्चन भी पूछ सकते हो तुम लोग. Move forward a bit. So now he is trying to apply the retractor. Maybe if it is possible, you can show them what kind of
What kind of retractor is it?
The Casper retractor, self-retaining.
So Casper retractor, this is self-retaining Casper retractor. Casper retractor has got 2-3 kinds of blades which are available. So one part of the blade is blunt. Okay. The another part of the blade may be some kind of surgery. When he's taking out, you will be able to see. You can see here. Can you see here? This part of the blade has got teeth in it. So this part of the blade which has got teeth, you will put towards the carotid side, under the longus colli muscle. Okay, so it holds on to that. And the other part, which is blunt, probably you can see little bit here also. So that goes below the longus colli, which is below the under the belly of the esophagus or the hypopharynx. Okay, so it goes below here. So it doesn't bite into the esophagus, doesn't bite into the structures which are above it. Ideally, one should try putting it below the muscle, but it is very difficult at times because there is no teeth here. It doesn't, many times it doesn't hold.
To avoid excessive traction on the tissue, it is best to do more of dissection of soft tissue, so that the local force of retraction is reduced. Most of the problems are because you are not dissecting the overlying soft tissues adequately, and then you try to retract the deep tissues forcefully. So whenever you think that you need some more exposure, it's best to start right from the superficial layer, dissect it out, and enlarge your exposure that way. Because you cannot achieve focal exposure without using excessive force, which is what usually causes dysphagia and problems of transient problems of anterior cervical exposure. So it's best to start dividing the tissues right from the superficial layer as you extend the exposure.
Now we are confirming the level. So once you have dissected, you have identified that this is the disc width. Before you proceed further, you must always confirm. There is no point in trying to be a hero by not using II. It is always better to confirm and check whether you are at the correct level. And how do you confirm intraoperatively? How do you confirm?
Now we are starting the process.
So you can confirm by putting a LP needle. You bend it in a shape of Z so that it doesn't go inside. You bend it like a Z-shaped needle and you put it inside the disc space, and you take a 1 X-ray and see to it that you are at the correct level before you proceed further.
So even starting compacting, the best is to remove the rostral and caudal disc first, so that you have some space to insert the jaws of your ronger there. This rongered bone can then be used as graft. Otherwise, if you drill it off totally, then you will have to have. In this case, we did need it, but then you will have to place another incision to harvest the graft from AIIMS or any other.
Can you slow down a little bit? Yes. Show them how to use the curette.
Yeah. Curette should be used with both hands always. because curette can get stuck and can slip and then can injure vital tissue. So you should hand over the suction to your assistant and then use curette with both hands. So that one of the hands can.
So one of the hands can be like I am holding this. You hold it from the top, and the other hand is to support like this. So in case it goes inside, you are able to hold it back. And see the movements of, I'm not sure whether Shashwat is operating or Hitesh. Hitesh is doing. So the movement of the curette should be inside out, like this, inside out. But if you are going like this, you will go into the disc space. Beyond it, and you will injure something.
You can plunge into the
Okay.
thecal side. So your movement should be out to
Inside out.
Yeah, inside to outside. Yeah.
And see how he's trying to take out the disc. Some people these days I've seen they try using drill to remove all the disc also. I think it's not a good idea because if you are not good in doing this, you will injure the end plate. If you injure the end plate, your graft will sink.
Another thing specific to this case is that in burst cases where there is a burst fracture, the fracture fragments are adhered or sometimes fused with the adjacent subjacent fragments. So we should not right away use a drill. We should first delineate. Like here I'm delineating the C5 fragment from the C4. Otherwise, you can even injure the C4 end plate.
Because some of the segments are telescopic inside because of the 5 forces. So you may not realize it, and that whether you are drilling the C5 or the C4. When fixation is required, then you will be devoid of any anchor point.
Okay.
From the compaction. So this is the C6 superior end plate. Inferiorly, you can see here. And this is the posterior cortex of the fractured body. Now this is also not very safe, to lever out the posterior cortex. It actually should have been drilled off and then should have been extracted gently. Because if you are trying to lever it, then your instrument can slip into the thecal sac also. But this was quadriplegic, so it doesn't matter. But when the patient is intact, then this should not be done. Now we are cleaning up the space. So the thecal sac is seen. Another issue is that when you are operating from the right side, you tend to remove more of the left side. So you should always be conscious of this fact and try to bias your exposure more towards ipsilaterally. Because opposite side is directly in your line of vision, so you tend to go more towards opposite side. And this is what actually happened in this case also. So the ipsilateral exposure is less as compared to the contralateral exposure. It should not be there.
So the PLL.
This is the PLL. Always the PLL is quite rough, and the dura thecal sac is quite smooth. So oftentimes you can confuse the PLL with the thecal sac, but then you have to realize that the thecal sac is very smooth, and your instrument will slip off the thecal sac easily, while the PLL is rough. And mostly if you have done an adequate decompression, then there will be bleeding from the venous plexus laterally. So that means that you are approaching the end point of your dissection. If you encounter bleeding from the venous plexus, so this is the perivertebral venous plexus around the around the vertebral artery. Okay, so now we have made enough room, I think, for graft. So graft for height. So usually in trauma cases, I prefer autologous bone graft when you are not doing a 360-degree fusion, because I want early fusion in these cases, because the posterior ligamentous complex is also damaged in these cases. So if you put in some artificial material, it takes long to fuse, and by that time it becomes unstable because the posterior ligamentous complex is also gone. So it is preferable, I think, to use autologous bone graft in these cases. See, the exposure is much more on the contralateral side as compared to the ipsilateral side. Contralaterally, you can even see the origin of the root there. Yes. See, that is the root origin you can see. So that means the exposure is more than adequate on opposite side. In fact, it should not have gone that laterally. It's not needed. Here we are removing a last bit of tissue, and it's important that you have a rectangular cavity before you try to put in the graft, because most of the times if you don't garden it out completely, like prepare it well, then your graft will not go in easily. So it should be in perfect shape before you insert the graft. So both the end plates should be prepared. There should be no residue of disc on the end plate, and the sides of the graft cavity should be parallel. Should be almost a rectangle. So that is what we are trying to do here. Okay. Now, okay, so I think the cavity. Okay, we achieve hemostasis. Last bit of tissue is being removed. Oh, yeah. Sure. Okay. 29, 30. Okay, now because there was kyphosis, so we put in two distraction pins on the superior and inferior vertebral body and at an angle, so that once you like they are like this, so you put them perpendicular to the end plate, so that once you place them on traction, then the alignment is achieved properly. Okay. So now we extract the graph. Okay, this is how we extract the graft, and then this is how we prepare it. all soft tissue should be clean, and then you can drill off with the matchstick burr, drill off the irregularities on the surfaces on the cranial and caudal surfaces with the help of this thing, a matchstick burr, so that it becomes plain and it's easy to insert.
Many times, most of you are not seeing use of the pediatric. One of you think that the use of cage graft, feed cage, everything is better. But this is what is the best thing.
So this is almost guaranteed fusion. See, we have now straightened out this cervical spine, and you can see that so a little bit of oversize, so I drill off some just a sliver of the superior surface, and it is always better to have some oversized graft a little bit so that you can hold on to the correction of the deformity. Okay, so finally we tamp it into place, and at this time it is important that it is a little bit countersunk, like it should not project proud of the plane of the cranial and caudal vertebral bodies, because when you put in a plate, then it will be a problem if it is sitting proud of the cranial and caudal vertebral bodies. So it is a little countersunk. You can see that. And then if there are any irregularities on this surface, on this surface of the graft, then you can drill them off to smoothen it, so that you have a very flat bed for the plate to sit on. And the smallest and the shortest plate possible should be used, because these grafts tend to resolve, and then if you use a long plate, then it will encroach onto the rostral or caudal end plate, and it can cause degeneration of that that spinal segment also. So it is advisable to use the shortest plate. So you should be able to see the cranial and caudal vertebral bodies through the screw holes. That is the measure of adequacy. Like yeah, the end plates. The end plate should be visible here. So here the end plate should be visible like this. The superior end plate, the end plate of the inferior end plate of the superior rostral vertebra, and through the lower hole, the rostral end plate of the caudal vertebra should be visible. So this is a measure of the, and then your screw should be convergent. Should be convergent in the axial plane, and should be divergent in the sagittal plane. So that will ensure that you have the longest trajectory possible inside the bone, and it will increase the hold of the screws by triangulation. And it is most advisable to use two anchoring pins in the beginning, so that you have the final position of plate, and before you are putting in the permanent screws. So these are usually self-drilling, self-tapping screws. So just you place them completely, and then I put some graft screws also through the graft to to ensure additional stability. When placing the graft screws, it is advisable to drill the trajectory completely so that you don't force the graft into the spinal canal when you are placing the screws. So this is how it was done. The final thank you. Post of it. So this is the yeah. So this is a post of X-ray. You can see that we have corrected the kyphosis and the graft is well placed. Spinal canal is clear. Okay. So these are the intraoperative images. हाँ ठीक है हो गया ना. Any questions anyone?
Maybe for 15 minutes, Dr. Borkar can show you something. In the meanwhile, we'll establish
I did it because I was not doing a 360-degree in this case, despite the damage to the PLL. So in these cases, I think that it is advisable if you are doing a corpectomy, you've already made it unstable, quite unstable, and there is a long graft that you are placing. So it does not hurt to put in graft screws. No. If the PLC was intact, I would not.
Hi, good afternoon. I'll be touching upon a very commonly performed surgery about meningiomas, more particularly the parasagittal and the falcine meningiomas. So these tumors, you must have seen such scans, big tumors in the parasagittal location. It can be an anterior third, middle third, or a posterior third, and this tumor grow large before they present to us. And they are quite intimidating as far as the scans are concerned. Obviously, some tumors are falcine origin, so they have a normal brain above them. The primary attachment is rather than parasagittal beside the sinus, it's in the inferior edge of the falx. So all these tumors are you will see more often in your practice. And there are some technical nuances which I would like you to know in approaching these tumors. So the primary thing in any parasagittal surgery is the taking care of the bridging veins, and we will in all such surgeries it is advisable you expose on either side of the midline. So the sinus, if it is preferable to have the sinus exposed in that particular region. So the burr holes on either side of midline and a craniotomy more on the ipsilateral side. And the most important thing is this cortical bridging veins, and this short video will tell you how to dissect the cortical bridging vein.
So this is the midline, and we have the dura has been opened and reflected over the superoccipital sinus, and this vein is stuck to the dura. You can't coagulate it, and without that you can't enter the interhemispheric fissure. So as you can see, we are tacking sutures here to reflect the dura towards the midline, and simultaneously doing a sharp dissection of the arachnoid at the tethering point. So the veins is a bit tethered here because of this arachnoid adhesion. We have to carefully underflow irrigation and a minimum bipolar setting as to divide these adhesions. I hope you can appreciate that it has to be done under high magnification.
Sometimes you can leave a dural triangle also. We find it too difficult to dissect, and there's no point. You can leave a triangular dural triangle. Cut the dura all around that.
Yeah, but yeah, that's another strategy. But that will still hamper your interhemispheric exposure. So if possible, try to dissect it. It takes time, but it's worth the effort. So this is what we are trying to do it. So though this video is of 5 minutes, I think it must have taken at least half an hour dissecting this vein. So it's important. Then once it is done, now it is the interhemispheric fissure is now you can expose it. We are using a glove with a cotton to to retract the sinus, and the tumor is now visible. It's a falcine tumor. So this is a general thing in how to dissect an interhemispheric, how to dissect the parasite breathing vein. And we come to another case, so which is a big middle 1/3 parasitical meningioma. The veins again are important here because if we damage them, the patient can develop venous infarct and weakness because it is just straddling the motor cortex. So it is again important to, this is what I was telling, the craniotomy, just we are going back. So any parasitical tumor, it's better to do such kind of craniotomy where you have the control over the sinus and you can reflect the dura completely or based on the superoccipital sinus.
So you may think that you are on the midline, but the sinus will be further pushed by the tumor towards
opposite side. So it's better we expose this.
So it's better to go across.
So the next step is again the tumor. And any meningioma, the principle is to devascularize the blood supply first. So the blood supply here is coming from the lateral wall of the sinus and the parts. So we are gradually devascularizing it with bipolar. At times there can be, it may be invading the sinus, so there can be a brisk bleeding. So you have to control it with gel foam. And do not open the sinus.
Do not try to
yeah, it's better to pack it and move to the other area. And this is what I was telling again the bridging vein. This is sharply divided, and we are trying to dissect this of the tumor. So this step is important because this vein is, if you damage this vein, there can be a major catastrophe. So we are trying to divide it. Again, these big tumors, it is important to not pull the tumor. You have to internally debulk with CUSA, with loop cautery, whatever means you have at your disposal, and do internal debulking, and the tumor will fall from the brain. So this is what exactly we are doing. We are trying to debulk the tumor. This is the loop cautery, which is being used. Again, we are trying to dissect the tumor from the arachnoid and we are not entering the fire at any point of time. We just want to be extraarachnoidal. So that will minimize the damage to the brain. And this being extraaxial tumor, it should be possible to remove it in this fashion. So in meningioma, you ideally should not enter the brain. It should be all extraarachnoidal to have the best outcome. So this tumor is now actually is going below these veins because it is wider below compared to the superior aspect. Again, internal debulking. We are now at the posterior margin of the tumor. There can be veins even at the posterior margin. Again, we are devascularizing, cutting and debulking with various instruments, the Caesar, the CUSA, the loop cautery, everything. This is the ventral aspect of the tumor. The vein has been dissected now. And this is towards the midline. There is some rim of tumor still left attached to the sinus. This is the last bit of tumor, which is attached to the falx. As you can see there, the glistening white falx is now visible. And that's the free edge. It's mandatory. We usually perform a MR venography prior to operating these tumors because at times the tumor may be invading the sinus. This is what is actually abutting closely to the sinus. That was also removed. And we secure hemostasis with Surgical. The patient had a good post-operative course. This is the post-operative scan. And except for a small tumor which may be abutting the sinus, the entire tumor was removed. With experience, you can even open the sinus and remove that tumor. But if now there are safer modalities available, like gamma knife, for which all these residuals can be either observed or given gamma knife. So thank you very much. We have oration coming up, so we will have more of this tomorrow. Thank you very much for your kind attention. Any question you can ask.
Hello,
Hello, Professor Sarvadi, how are you?
I'm fine. I'm fine, thank you.
How are you?
It's about the night sometime.
Good. Just a few more minutes and we'll start. Right on time.
Okay, perfect.
Thank you. Thank you.
Do you want me to try to share the screen or we can wait?
Yeah, we can try. We can do a try. That time you're logged in a little bit earlier. We can try.
Okay, I try it now. No, it's not possible. It says that you didn't allow me to do it.
Let me allow you. Now you can do. Now you can try. Try again. Again. Now we can see your screen. Not a problem.
You can see my screen, even full screen now.
Yes, sir, we can. We can see your screen.
Okay, perfect. So we go out.
Okay. Okay.
So we will mute ourselves and we'll stop our video for just a very short period of time before the director comes.
You do what you want. You tell me what to do, I do it. No problem. Thank you.
Thank you so much.
You're leading me. You tell do like this and I will.
Okay.
Good afternoon, Dr. Tandon. Good afternoon, Dr. Banerjee.
Good afternoon.
So I see that the links are working and you're already online. Very good.
Dr. Franco,
Yeah.
we made you the host for the meeting. For the initial part, you will have to make us the host again. So that we have to show your slides, few of the slides we have to show initially. We will introduce you, we will introduce provide introduction about the origin. And then you will be asked to show your slides. So for the initial part, you will have to make us the host again.
So, but for what? I don't have to show any slides for the initial part. You do it, correct?
Yeah, initial part, we will start the official proceeding from here, and then we will invite you.
Okay. Whatever you want. Okay. Hello. How are you?
I'm good.
Well, I am without mask because I am alone here, including my office. I recognize you. No worries. No worries. It's okay. Respect the procedure. We have the same procedure. But here I am alone, so I can be without.
So you have to click on the area where neurosurgery AIIMS is written, and on the right side you will see there are 3 dots. You will have to click that. Once you click that, you will see make another person the host. So you will have to make us the host again.
Well, I don't see where it is. I have 3 points here, but
Click on the 3 points.
yeah, I can click, but there is only Facebook, YouTube, and streaming, nothing else.
There's a link displaying the participants just at the bottom of the screen.
At the bottom of the screen, link for the participants. Can you click on that?
No, I cannot see it. Well, the only thing I can do is for you is going out and in again. So it will be no problem. Okay? I go out now and then I come back again. So I think in this way we can interrupt it. Okay?
Yeah, I think we are good. Can you hear us, Dr. Sanjay?
You can hear me? Can you hear me?
We can hear you. And once we invite you, we will make you the host so that you can share your screen. Right now, we are the host, and we will invite everyone, so they will be able to share the screen from here.
Okay.
Okay.
Good afternoon, everybody. I welcome you all on behalf of Department of Neurosurgery to the 23rd AIIMS Annual Microneurosurgery Workshop and the 31st Sarveshwari Memorial Oration. As we all know, this oration is the heart and soul of this annual conference, and each of our residents and faculty look after it every year. And we are all witness that as a tradition, this oration has been delivered in the past by the giants in the field of neurosurgery. So without wasting much of the time, I would like to invite Professor S.S. Kale sir to introduce the oration.
You have to share the screen oration. Tell me when you're ready. Okay, a little bit of hiccups. I think this is the first time we are having this hybrid concept as far as our oration is concerned. So, anyhow, it's always good to try something new, especially in this pandemic times. So, ladies and gentlemen, a very good afternoon to all of you. Welcome to this 31st Sarveshwari Memorial Oration. As every year, this oration is actually an All India Institute of Medical Sciences oration, and it was started. I mean, this is the 31st edition of this oration, and it is in the name of late G. Sarveshwari. Previous slide, please. Yeah. So she was born on 10th June 1947, the eldest child to Mrs. and Mr. G.S.K. Rao. Mr. Rao is an electrical engineer. He is from Bangalore. She had her early schooling in Andhra Education Society School in Delhi, which is affiliated to the Central Board of Secondary Education. Thereafter, she did her BSc Honours in 1968 from Delhi University as a student of the Miranda House College. It's a college only for women and a very prestigious college in the Delhi University. Somebody please take care. Is this screen being shared? Okay. Go back, go back, go back, go back. Yeah. She was an excellent student and stood first in the Delhi University in her Masters in Botany. She was awarded the Panchanan Maheshwari Memorial Prize for her achievement. And soon after her MSc, she got married and she settled down to a happy married family life. Between 1968 and 1975, she became the proud mother of 3 children. Next. The first symptom of brain disorder was noticed in May of 1974 in the form of severe headache and loss of consciousness. The project directors, doctors of Balco at Korba, that's a big aluminium company, at least it used to be, the Bharat Aluminium Company at Korba. That's where her husband was employed. The doctors there referred her case to All India Institute of Medical Sciences, and here she was diagnosed to have a malignant astrocytoma. Next. She was operated upon on 12th of March 1976 and a radical tumor excision was performed. This was followed by radiotherapy. She made a quick and a complete recovery after the surgery, but the tumor recurred within a year and she succumbed to her illness on the 3rd of February 1977. Next. This oration was then instituted through a munificent grant by her loving husband, who incidentally is online and he's watching this whole proceedings, and many times he actually flies down to Delhi just for this oration. The first oration was delivered in 1981 by Professor Christian Christiansen of Oslo, Norway, and over the years there have been literally a litany of distinguished orators who have graced this auditorium or the other auditoriums in All India Institute of Medical Sciences. And some of the highlights or some of the big names have been Dr. Rasmussen, Professor K.V. Mathai, Professor Bricolo, Professor Crockard, Professor Coldwell, Andrew Kai from Australia, Arnold Menezes, Dr. Kawase, Tashling Pang, and last year was Professor Fred Gentili from Canada. So, after this brief introduction, I now hand it over back to the MC for today evening to carry over the rest of the program.
Thank you, sir, for giving us the introduction regarding this oration. Now, I would like to call. I would like to invite Professor Dr. Deepak Gupta, sir, to introduce the speaker.
Good afternoon, everybody. At the outset, I want to thank really Dr. Kale, who asked me to introduce our orator for today, Professor Franco Savade. It's a very proud moment for me to introduce Professor Savade, whom I met, I think, 5 years back in Milano. Professor Franco Savade is currently the Residency Program Director and Neurosurgery Professor at Humanitas University in Milano. To talk about his education, he did his graduation in medicine from the University of Bologna in 1976. Subsequently, he did his initial training in neurology and then in neurosurgery from the University of Bologna and Modena in 1985. He was the first resident neurosurgeon in Sweden, and later on he became the first resident and then the staff neurosurgeon at Bellaria Hospital, Bologna in 1988 to 1989. To talk about the various important positions he held, he was the Registrar of Neurosurgery in Edinburgh, Scotland, and he was the consultant and initially and later on he went on to become the chairman of Neurotrauma and Emergency Department in Caesarea. Later on, he was the director of neurosurgery and neurotraumatology and also the chairman of emergency department of Parma. This is where I met him a few years back. He has also held positions of teaching professor at Ancona, Catania, Parma, and Padova in Italy. Currently, he is the residency program director and professor of neurosurgery at Milano. To talk about his work experience and appointments, he has held very important positions in various international and national neurosurgical and neurotrauma society, which includes the presidency of Italian Neurosurgical Society, the chairman of Neurotraumatology Committee of WFNS. In fact, he has held the office of more than 12 years as an Italian representative to the Neurotrauma Committee. And then later on, he went on to become the president-elect, and currently he is the president of World Federation of Neurosurgical Society. He is a reviewer of very prestigious, very high-ranked neurosurgical journals, which includes Journal of Neurotrauma, World Neurosurgery, and Neurosurgical Reviews. His two mentors were from outside Italy. They were late Professor Douglas Miller and Professor Graham Teasdale.
and they were actually mentored by Professor Brian Janet. Many of us must have heard about Janet and Teasdale Glasgow Coma Scale. So probably his interest in neurotrauma comes from his Scottish influence, and his commitment to hereditary care continues on even till now. To talk about his work and his, I think he works, he speaks, and he publishes. He has over 5,000 neurosurgical operations as a first surgeon to his credit, and he has given international lectures all over the world. And to talk about his publications, of course, like any other neurosurgeon, he has got avid list of publications with a H index of 44. But his landmark and seminal papers have been on the helmet law in the Italy, and of course, talking about the importance of the worst CT scan in decision making. And currently, as a WFNS president, his main focus is on COVID-19 and neurosurgery. He is in the advisory board of Brain Trauma Foundation guidelines, which all of us read for many, many years altogether. And probably is one of the key person who is talking about something called as a consensus-based guidelines, because now people are talking more about the consensus and less about the evidence-based guidelines. And he's probably one person who emphasizes repeatedly to all of us that 89% of the publications in traumatic injuries, they come from countries that see less than 10 to 15% of trauma. So he strongly advises and is a big proponent that we from our country should be the leader in publications internationally. To talk about the awards, he has received various awards in various platforms. In fact, our Neurosurgical Society of India gave him, conferred him with the Ginde Award in 2018. Our DNA Association gave him an award just for 2 years back. And very recently, he received Lifetime Recognition Award by American Association of Neurological Surgeons in April 2019. He is holding various honorary professorships and positions in various parts of the world, which includes Russia, Indonesia, Africa, Cambridge. He has received various grants, heavyweight grants, I would say, and he is the principal investigator of many major landmark big neurosurgical and neurotrauma trials. Now, a road to presidency of WFNS is very it's a very big journey, I would say. And very surprisingly, if you read the letter from the secretary, Dr. B.K. Mishra, written in 2015, his name was not even proposed to become the WFNS president. Like he was in the contest in this, but his name was not proposed. But yes, he went on to become the WFNS president. So he is the one person who has actually rose up from the ground and attained the highest position in Neurosurgical Society of WFNS presidentship. He has got avid interest in mentoring young neurosurgeons, and he is very much interested in inviting neurosurgeons, especially from the low middle income countries, to his center for training. When I last met him, I asked him, as a WFNS president, what will be your priority, sir? His answer was very simple. I want to focus on meningiomas, neurotrauma, hydrocephalus. He's a very simple man with deep thoughts and who has got revolutionary abstract thinking. Today, Professor Savade is with me, and I think many of you would have seen this picture on the left side, hundreds of military trucks taking dead bodies, coffins out of the city because the cemeteries were full in the whole of Italy last year. Many people died and there were no places to bury them. And today, I came to know that the Prime Minister of Italy, Mario Draghi, he will be actually paying respect and homage and a silent 1 minute silence in probably 15 minutes from now in the memory of the COVID victims. And flags will be half past in Italy today and some time from now. And I just want to say to Professor Franco Savade from the Department of Neurosurgery for All India Institute of Medical Sciences, we are there with you and our prayers are there for the departed COVID souls on this important day. Behind every successful man, there is always a woman, but he has got two women behind him. The one you can see in the picture is his wife, Constanza, and she is an endocrinologist. And the second woman is his beautiful daughter, Francesca. She is a lawyer working in an international office in Milano. He is also blessed with a son who is an informatic engineer in Munich, Germany. These are a few pictures with his friends, and his focus, of course, is on low middle income countries. He was born on 7th of August, and many of you who believe in the zodiacs, they are the ones who are kind of Leo sun sign. And he is truly blessed with all the qualities. I just want to read out a shloka in Sanskrit, न अभिषेको न संस्कार सिंहस्य क्रियते वने विक्रमर्जित राजस्व स्वमे नरेंद्र. To translate in English for Professor Franco, there is no official coronation ceremony held to declare lion the king of jungle. He becomes the king by his own attributes and heroic actions. Similarly, a person can achieve a position above others with his virtues and efforts. Ladies and gentlemen, I think he's truly the doyen, or like we call in India, the Singha of neurotraumatology. And as a WFNS president, he truly justifies to be called the president of WFNS. I welcome Professor Franco Savade. Benvenuto, Professor Savade, for this oration. Thank you.
Okay, can you hear me? Everything okay? Okay, thank you so much because I have a noise in the back. I am not sure you can hear me. So after this introduction by Deepak, who is a long-standing friend, and I have to thank, first of all, Dr. Gulera, Dr. Deepak, and Dr. Vivek for the invitation to this Sarveshwari oration, prestigious oration. I have been, when I was president of the WFNS, elected 2015. Now it is 2021, and I have traveled in this period to more than 41 countries to be the president of the WFNS. The country where I was more times and more long time is India, even more than European countries. So I have a strong link with India and with our friends, the Indian neurosurgeons. I share my screen to start the presentation. I will speak about a topic which in the middle between social pandemic and neurosurgery. I thought it was appropriate in these circumstances to show you what we neurosurgeons are doing all over the world to fight the COVID and to keep neurosurgery working, which is a difficult task. These are my conflicts of interest. Obviously, they have nothing to do with today's presentation. This is the situation as yesterday. You see that we have over 120 million cases of COVID with 2,600,000 deaths, variously distributed in the world. You see that if we look at the distribution of COVID, this is America, this is Europe, this is Southeast Asia. There are differences. So we see that the numbers are quite different between various continents. If we look at the death per population, we see that we have Mexico, but then we have a series, including my country. My country actually was the only country in the world with 3 waves of pandemia, 3 full waves of pandemia. Now we are in the middle of the 3rd wave. And you see that many European countries are in this area, are very badly located. And India is here. So the number of deaths, you know very well, better than me. And you see that these are the vaccinations all over the world. And you see that there is
an increased capacity of vaccination in some countries like Israel, UK, Chile, and US, and in countries, some other countries, very little has been done. So the first message is that pandemic is not the same all over the world, is different. How did the neurosurgeons react to the pandemic? Via publication, let's say, we know that in almost just a bit more than 1 year, 106,000 papers were published all over the world concerning pandemic. So it's by far the largest publication number for a single topic in the history of medicine, you all know. And these are the countries contributing. You see China in US, my country is third, and then we have UK, India is here. So there is a large contribution of Indian scientists to the publication in pandemia. And this is a very interesting paper published on the Journal of Neurosurgery, showing how many publication and papers were sent for publication. And you see, this is 2019, this is 2020. The number of publications more than doubled sent to the journals. What does it mean? That the neurosurgeons felt very involved in the issue. And you see it here, if we look only at COVID and neurosurgery, these are the publishing country, and India became the fourth publishing country. So you are contributing every day to publication in the field of neurosurgery and COVID in an important way. You are the fourth country in the world after US, China, and Italy at the moment, and you are raising up. These are some of the publications to show you that the contribution is from everywhere. China, Spain, Italy, Germany, UK, Belgium, France, US, Canada, Australia, Dubai, India, Indonesia, Africa, Philippines. Every neurosurgeon, every part of neurosurgery in the world has published. I was the editor of a special issue on neurosurgical focus called COVID-19 and Neurosurgery, which was published 1 month ago. And this issue is entirely dedicated to the neurosurgeons who lost their lives in the battle against the COVID virus. Yesterday, as World Federation, we received, every day we receive a notice of death all over the world by neurosurgeons. And yesterday, I have to tell you, this news is terrible. We lost a young resident from Indonesia and another young resident from Mexico. So it's no more that people over 70 is dying, but we have residents dying because of COVID. So it's a terrible disease, and we have also to think about in this issue. As you see, we published 20 papers. Out of 20 papers, 3 were from India, and you see 6 from low and middle income countries, which is exceptional. I was the editor together with William Caldwell, that I have seen was already here as a speaker, and we decided to give to this issue an international, let's say, roadmap. And you see it here, if we look at the number of publications all over the world, only the low and middle income countries only represent 5% of publications. And most of them are from you, from India. So we were also very happy that when we decided which was the best paper in the issue of neurosurgical focus, a paper from you, from the AIIMS in New Delhi was taken as an example, and that's the best paper of the whole issue.
So we have to congratulate with Indian writers and scientists, but also with you in your institute. How do we keep the neurosurgery working? We had 5 important surveys all over the world. You see it here. One survey is from US, this one. One survey is European. These are Italians, Germans, Swiss. One survey was organized in a multi-center way in Africa and South America, another European survey, and the big African survey. So we have 5 parallel surveys about the attitude and work of neurosurgeons in the period of COVID. And you see it here, the main complaint was that we were not prepared to face the pandemic. Most of the neurosurgeons felt that they were not enough prepared, and this is Africa. Most of the African neurosurgeons say that the guidelines they got from government were either non-existing or not applicable. And also important because we have to know which are the devices available all over the world. You see that N95 devices in Africa are available only to half of the surgeons. Over half of the surgeons do not have them. Still now, this paper has been published this week. So the other issue is that the vast majority of the non-emergency elective surgery was either cancelled or deeply affected by the pandemic. This is all over the world. Where now, in 2 hours, we have a meeting to decide how do we deal with the third wave of pandemic, in which surgery are going to be again cancelled. I say again because it's the third time. March last year, November this 2020, and now. So it's the third wave. As you see it here, there were a lot of guidelines. How do we deal with non-emergency neurosurgical operations during the pandemic from America, from the Europeans, from the Europe, from British, from everywhere. And also, we had researches, allocations, and suggestions from Mexico. You see it here from you, from India, and from your institute and other 3 institutes in India. And this is an interesting European study showing the same disease, what it will happen before the pandemic and during the pandemic. And you see, this is a malignant glioma. Before the pandemic, everybody was convinced to operate him. After the pandemic, 1/4 of neurosurgeons say, no, I'm not going to operate. The same for spinal stenosis. Before the pandemic, everybody wanted to operate. After the pandemic, of the surgeons say, no, I'm not going to touch it. So the surgical indication changed in this way. Which part of neurosurgery was mostly affected by pandemic? This is a UK, a British survey, and you see that degenerative spine disease here, down during the wave, and neurotrauma were mostly affected by 2 different reasons. Spinal disease, because elective surgery was cancelled. And as you see it here, the traumatic brain injury, we will go in depth. I have written an editorial for Acta Neurochirurgica recently, and the situation is that all over the world, even in India, your paper confirms that there was a 60% reduction of trauma because of the lockdown, and the same is true all over the world. You see Ireland, Italy, Austria, UK,
New York City, all over the world, the lockdown period caused a favorable, positive effect of trauma reduction. And these are Italian data where you saw 16, 17, 18, 19, 20, big drop down. So we have dropped down in trauma, but we have a big drop in availability of ICU, for instance. So we have two problems. One problem is that to treat TBI, we don't have any more ICU because they are devoted to COVID. And then the disruption of peripheral hospital made it very difficult to maintain the admission of trauma patients. So this is one. Then there is another sector of neurosurgery where we had problems. As you see, this is one of the first, probably the second paper on endoscopy ever published, and you see that there was a fear of COVID transmission in OR because of the first Chinese paper and then other papers coming from my countries and other countries, that the exposure to respiratory instruments going through the nose will increase the risk of spreading the disease. And there were a lot of technical issues. These are two Italian papers coming from very well known, like Paolo Capabianca endoscopic institutes. They both have devised the coverage of the nose via a double transparent steri drape, which has been crossed by endoscopy and protected with a double transparent. So there was, in a way, a suggestion of better protection. This is a paper from Singapore, which I think is too extended, in which our colleagues use PAPR. You don't know, you see it here. Very difficult to use during surgery to operate patients with non-COVID via endoscopy. This is a survey just published, you see in Neurosurgical Focus, is a global survey about the practice. You see that we have, in this survey, there is a teaching that I want to tell you. You see that it seems that the access to N95 protection or even N95 plus PAPR is easy because everyone has it in this study. And there is another interesting finding. Whatever you do, N95, PAPR, whatever you do, the infection rate is similar. So 19 out of 137 exposed to this surgery became positive to COVID after surgery, but they were wearing N95, PAPR, any kind of mask. So it seems that the protection has little to do with, or is not the only factor protecting ourselves. As I told you from this report, it seems that N95 is common, we all can use it. This is the paper that came out from Egypt saying only 18% of the surgical team were using N95 masks. So it means that in a large part of the world, still they are not available and they are using simple surgical masks. In this setting, in this poor resource setting, there was a revival of transcranial surgery for pituitary adenomas to avoid exposure through the nose. So we do have two parts of the world with two different protections. Then another issue that we have faced, and I think you have the same problem is transforming neurosurgeons into pneumologists because the number of pneumologists or internal medicine doctors, physicians, is not enough to cure all COVID patients. So you see, suddenly we were forced in less than 1 month to send all our neurosurgeons, most of our neurosurgeons to COVID wards. And now we are better organized. By today, as I told you, we are sending 3 of us, 3 young neurosurgeons to the COVID areas to help to cure patients. And but the good news is that our chief pneumologist, one of the 2 we have, Francesca, who is a young lady, said that the young neurosurgeons were the quickest to reconvert and among the best to cure our patients. So our young neurosurgeons unexpectedly were shown to be able to be very good doctors, to be in the role of the physician curing COVID, one of the best specialty for maybe because we have a part of our training in ICU, so we are able to reconvert quickly, but this is a fact. And these are our American colleagues who have delivered the guidelines how to become to care the pulmonary part of the COVID disease. Then we have to keep neurosurgery alive whenever we are attacked by the pandemic. In Italy, as you say, already we have a system in part of Italy where we cure trauma through an hub and spoke system by concentrating patients to few hospitals whenever there is a need for reducing beds in the other hospital. This system was already in place in 2017. When we entered into the storm of the COVID, we used the same system to concentrate patients in few hospitals. You see, this is a Zoom seminar that we do every week, and we discuss patient concentration. And you can get this paper where we published our experience, and you see that we could deal with a tremendous wave of COVID by keeping patients in a few hospitals and moving neurosurgeons to cure the patients. And this is your paper from India where you were just referring to our patient and you had a similar way to treat patients within your institute. So we think the so-called hub and spoke system, by having a few hubs which are open with the ICU is clean from COVID patients, is the only way to have to cure large numbers of COVID. And another system that you were discussing also is the so-called 3 teams organization, having 3 parallel teams who are rotating. One is working, 2 are at home, who can exchange the doctors, the neurosurgeons, and they can keep the surgery alive even in the case of contamination. Then the use of telemedicine when we have a COVID period, when we have a pandemic, patients travel long distance, or our neurosurgeons need to keep in touch with their own patients. This is a systematic review that published recently, where you see these are all the papers published on telemedicine. I don't go into details, but you see that the telemedicine field has become more important in neurosurgery over the years. We can obviously reduce the number of visits, reduce the number of outpatients, and discuss transfer triage by the extensive use of telemedicine. The only problem with telemedicine is that we frequently have failures due to technology. So we have to back up and be ready to prepare an alternative. But this is your experience in India. But what we have learned is that most of the post-operative controls, I mean, many patients are traveling long distances to show you a post-operative NMR or to show you and talk about so this all can be done via telemedicine. Most of the follow-up at distance are in scales, and the scales are validated for an interview via video, so we don't usually need it. Then there is the issue of preoperative testing. This is a big issue all over the world. You see that this is Indonesia. They have done a very complicated draft by using PCR test for some patients, but not everyone. Some patients rapid test, some patients nothing. You see, this is due to the availability of PCR testing with us now. We do a molecular testing all patients 48 hours prior to surgery, and we repeat it before discharge at 5 days or at 5 days after operation. As you see it here, this is not possible everywhere, so we may use in alternative chest CT scan, or even we may use quick testing, non-molecular. Then we have a very interesting paper just published. It came out a week ago, which is how to change the future of critical care. You see this here. I don't go into details, but you see this. Which strategies we have to expand ICU, and obviously we have to expand the number of working hours, increase the number of patients per staff, to use non-ICU staff like neurosurgeons, and to transfer patients from less resources to better resources at hospitals. So we have to think to a new ICU with more possibility to improve beds, to flexible ICU staffing, to flexible ICU consumable and pharmaceutical. We need to think of an ICU as expanding and closing in a way in which we can face the pandemic. Then the last part of my talk is entirely about the change in training. We have been all deeply affected by the training changes that we saw. You see it here, and this is a survey all over the world, and you see that most of research and scientific training has been cancelled in many countries in the world, and it was a deep decrease in learning activities. The reaction is different, but there was a reaction from everyone. This is US and Canada. You see that 96% of residents had reduced hours, and almost all residents have a shift of teaching from in-front teaching to, as you see, remote and teaching on electronic platform. This is my country. We have 24 programs all over the country. We joined together. We have never done it before. So it's one of the few positive effects of the COVID. We joined together and we opened a common platform for the teaching from remote. So we also, you see that from 39 participants to 485 participants in the last webinar. So we have increased the community of neurosurgeons and neurologists taking part to these meetings. In India, it was the same. This is the paper for training in pandemia from Indian perspective, and you see that also online platform, routine classroom, everything. This is also from Indonesia, Malaysia, Singapore, and Thailand. You see it here. Again, many differences, but the same meaning. How do we teach from remote to our students? And this is another positive message, one of the few from this pandemic. The African neurosurgeons say we were happy to get into a webinar system where we could learn from the masters in neurosurgery free. There was no cost. So suddenly we were exposed to high-level teaching on the platform for free. Before, you have to go and travel to congresses, you have to pay the fee of the congress, you have to pay the travel. Most of these African neurosurgeons couldn't do it. But now, on electronic platforms, you have the possibility to get access to the best teachers in the world. And this is a survey done in low and middle income countries. You see here, the survey was done mainly by us, by the World Federation, in Africa and Southeast Asia, including in this region, India. So most of the trainees who responded were from this country, and obviously all say that the training was deeply affected. And then we ask them, what do you want we to do in the future after the COVID? And they ask about an online curricula, virtual lab, collaboration between high and low middle income countries, and the regional gray lab. So these are the requests of our young neurosurgeons. How do we deal with COVID? How do we survive after the COVID? Then what the World Federation has done on 5 March 2020, more than a year ago, we stopped all in-person meeting through the world on behalf of the World Federation. I was criticized because they say most part of the world the virus was not there, and luckily I was right. After 1 month, everything was closed. So this is the letter that we have posted. So what we did as World Federation, we already had one part of our teaching was already on the web. You see, this is May 2018. This is the webinar, and we had 1,300 contacts on YouTube. So you see that this was already there, or the spine committee of the World Federation had already a series of webinars addressing different topics of spine on the web. But now is an explosion. You cannot count webinars, scientific webinars on the web. I don't know if you know it, but I've seen the data in a meeting 2 days ago. India is now the second worldwide country as number of educational webinars. So you have come very up in the scale of those one using webinars for education, and you see it here all over the world. We are the flowering of webinars. What do we miss when we use webinars? What is the missing of the webinars? First of all, we miss the on-site so-called teaching, the cadaver labs or the teaching in the operating theater. We need the mental and manual skills, and we only have to do it. We can also do it in the operating theater and in the cadaver lab. But there was a kind of discussion about the simulation. Simulation in neurosurgery became extremely important to shift to a system where we don't need a cadaver lab. but simulation instruments are very expensive. Therefore, we already wrote a paper, you see it here, where we say that digital teaching is important in countries with limited resources. And this paper was published in 2018, so already, and you see it here, that we can have the possibility to get a three-dimensional virtual intraoperative reconstruction for education via an iPad. And this is a European project called, you see it here, is an European project which was financed by the European Community in 2020, and is a joint venture between two startups, one is Italian, one is UK, working together on a free training program all over the world where you can use your iPad or your phone. So I come to the end of my presentations in this field. The first issue is that as president of the WFNS, I would never think about dealing with such a tremendous nightmare. But let's say we can take some few positive messages. First, we all discovered that we are doctors first. We are physicians first. Only then we are neurosurgeons. Before we thought we are neurosurgeons, we are very important, we do a fantastic job, we are not caring about the other part of medicine. Now we understood that we can effectively care about a need of the society, a need for doctors who can work in COVID when we need it. So the Latin say mater artium necessitas means necessity is the mother of invention. So we discovered that ourselves can work in other fields apart from neurosurgery. And second, we discovered also again as a positive message that web-based education is free and can reach anyone in the world. That this is one seminar that I did a week ago, and the seminar was, you see, Uganda, greetings to everyone, thanks Professor, Libya, Yemen, Kinshasa, Congo, Mongolia, all over the world, neurosurgeons who could never go to meetings before are exposed now to our speeches and to our presentation. And obviously this is here to stay. Then we all learned how to prioritize surgeries and to keep emergency neurosurgery alive in difficult situations. And also our residents learned to work together at distance with other hospitals and universities. And we also learned the one thing which is extremely important. We cannot follow general guidelines, but we need to adapt them to our local environment. We have seen, I've shown you, huge disparities in protection and swab test availability, and subsequent different action to be taken. As I've shown you before, in some part of the world, with the protection we have, it's not safe to operate via endoscopy. We need to operate the patient from above. In other parts of the world, where we cannot do swab test every 3 days as we are doing molecular testing, we need to find other ways. Chest X-ray, quick test. So the second Latin sentence, which is ex malo bonum, means even from the worst experience of our life, we can take positive messages. And as I told you before, the positive messages are adapt ourselves to be something else, not only neurosurgeons. Second message, we have learned to prioritize our surgeries. We are not done before, but we are doing now. Third, we learned how to use the resources we have to get the better. Now the target that we have in this third terrible wave is not closing everything, is keeping neurosurgery alive and win the battle against the COVID. We now have the vaccinations. Vaccines are going up and down. You know that in Europe, the vaccine Alpha Zeneca vaccine was stopped. Today, probably we can restart again. But you know, there are a lot of emotional feelings about vaccine. One of the feelings is that the vaccines should be 100% sure. There is nothing 100% sure in our life. Why should we expect the vaccine to be 100% sure? Nobody knows, but this is the feeling, the newspapers, at least in Europe. So we are fighting to get more and more people vaccinated. We are fighting as a community of neurosurgeons to go ahead and keep the life of our patients good and ensure quality of treatment for our patients in neurosurgery, even during the pandemic. So I am very happy to be with you in India, even from distance, and I really thank you again for the invitation. We had this is the Dome of Milano you see in this terrible period, but you see, the period is terrible, but the dome is there. Our history is there. The meaning of our man is still there. So we will not lose it. Thank you so much.
Thank you, Professor Sarvade, for giving us your precious time and enlightening us with your views and experience on this. Okay. Thank you, Professor Sarvade, for giving us your precious time and enlightening us with your views and your experience on this undoubtedly the most relevant topic at the present time. Now, as a part of the tradition of this oration, I would like to invite Professor Ranjit Guleria to felicitate the orator.
Professor Sarvade, what we will do is to show you the plot on camera. And I promise you I'll send it over by mail as soon as it is possible. So, please. This is the camera.
Thank you so much for the honor. Thank you for the plate, and don't worry, I'm sure it will come. I will see. I hope to come to India very soon to get it.
And we send the flowers too. We send some flowers or at least some electronic flowers to you.
Thank you so much. Thank you. Thank you.
And this is the something to put on your wall.
I have the wall, my office just in the back. So it's perfect. Thank you so much, all my Indian friends. I was really happy to be with you, and I hope we will defeat this nightmare. I give you one information. The World Congress of Neurosurgery, which should be in Bogota in August, has been shifted to March. So I inform you, all of you and the Indian society, share this information with your friends that the Congress will be shifted. Obviously, unfortunately, we cannot do anything now.
Okay, thank you. Thank you very much, Professor. Thank you, sir.
Thank you to all my friends. I hope to come soon again to India. Thank you. Goodbye.
Definitely. Definitely.
Now I would like to invite Professor Sharat Chandra sir to give vote of thanks. So in a way, we have actually concluded the vote of thanks, but it still remains a formal affair. So on the behalf of the Department of Neurosurgery, obviously we would first like to thank the speaker, Professor Sarvadei Franco, for his excellent oration and very relevant oration, which is very much relevant for our situation here. And I'm really glad that Professor Guleria was able to hear this oration because our institute has been the forefront for developing preventive strategies, treatment strategies, and also being a role model for creating similar strategies all over the country. I don't think just all over the country, but all the adjacent countries and many parts of the world. As a part of the formal vote of thanks, I would like to thank first the husband of Srimati Sarveshwari, who is online, Sri Radhakrishnan, who has supported us, whose family has supported us with this oration. My vote of thanks would not be complete if I do not thank our Director, Professor Randeep Guleria, our Dean, Professor Anita Saxena, Sub-Dean, Professor Rajiv Kumar, Registrar, Professor Sanjay Lalwani, without whom this would not have been possible. And again, this vote of thanks is not complete until I acknowledge our senior teachers and mentors whom we were very happy to see online. Professor P.N. Tandon, Madam Tandon, I could see them listening to the oration very keenly and we were very happy to see them. Professor A.K. Banerjee, Professor Ravi Bhatia, Professor Mehta, Professor B.A. Sharma, all of whom have been the heads of our departments, chief of the centers earlier, and have been our mentors and teachers, and have been supporting this oration and workshop year after year. And of course, lastly but not the least, I would like to thank all the delegates who have been coming year after year. This particular workshop and oration has been difficult. Even few days ago we were contemplating should we hold it or should we not hold it, but thankfully we went ahead and held it. And as is the tradition, I invite all of you to join us for a cup of tea as well as snacks outside, and hope that we get back to normal as soon as possible. So stay safe all of you and enjoy the rest of the microsurgery workshop. Thank you.